beginning with the antimicrobial stewardship. So what is the basic definition? The definition of antibiotic stewardship, it's a coordinated, measurable effort to improve how antibiotics are prescribed and used. So each patient receives the right drug, the right dose, the right route and the duration of treatment, while simultaneously taking care of reducing the toxicity, the cost of therapy, the occurrence of C. difficile, and most importantly, antimicrobial resistance. It involves patient safety programs which improve cure while preventing avoidable harm, quality improvement program which measures decisions and feedback, and public health program which reduces the selection and spread of resistant organisms. So you need to start smart in sepsis and then focus aggressively at 48 to 72 hours. Now, what is the stewardship question that you should have in mind before you're thinking of prescribing an antibiotic? First of all, and the foremost, are you dealing with an actual infection or a syndrome, or are you dealing with a mimic? And how severe or the infection is, and what is the source? How is your host? How is your patient? Is he an immunocompromised host? Is there a history of prior antibiotic use or prior cultures or colonization? What sample do you need to send? What appropriate sample from the site of infection, or what samples together do you need to send? And then the empiric therapy that you're choosing, does it actually penetrate the site of infection? Are you keeping the PK/PD in mind before selecting your empiric therapy? And then what to review at 48 to 72 hours, and the duration, for how long are you going to give this antibiotic. You cannot just think of an empiric cover and just continue it endlessly. So you have to have everything in mind before you think of a prescription. Now, components of an ICU antimicrobial stewardship program, the CDC 7 core elements include the leadership commitment, which involves people who are going to be involved in the stewardship program, accountability, wherein you appoint people who lead the program. Then you have the pharmacy expertise who take care of your dosing, switching of IV to oral, and giving you the safety support. You need to have an action team who can actually do an active feedback and pre-authorization. Tracking, what would you track? You would track the duration of treatment, the development of resistance, occurring of C. difficile infection, then reporting as well as education. Then when you're taking your ICU rounds, what it should look like. You should have a daily antibiotic timeout, an ICU specific antibiogram, a diagnostic stewardship, PK/PD optimization, source control partnership, ring fencing of novel agents, and IPC integration. So we will understand this as we go ahead. Why stewardship belongs in every ICU? Why is it important? Why do we need it in the first place? Because most ICU patients receive antibiotics at some point. So there is a high exposure. And critical illness, obviously, when you have a patient who's sick, you want to, cover urgently, and you want to give a good empiric broad cover. Low certainty, because microbiological confirmation takes time and sometimes it is delayed. And there is a risk, there's always a possibility of colonization, which can masquerade an infection. And naturally, there is a high consequence. Why? Because when you're selecting a broad therapy, there is going to be more occurrence of antimicrobial resistance if you don't have a proper stewardship in place, more occurrence of maybe C. difficile, and even you're going to be dealing with more toxicity, more adverse reactions. So it is very important to understand the reason why you have to have a proper stewardship. We know that with the antimicrobial resistance crisis globally, the deaths directly attributable to bacterial antimicrobial resistance in 2019 was almost 1.27 million, and 4.95 million deaths were associated with bacterial AMR in 2019. And we all know that when you think of the ICU pathogens, it is the escape organisms which account for the major share of the resistance associated with mortality. Why is India different? Why things are different here? Because consumption, we know that in our country, the use of antibiotics is very, very substantial, and sometimes it is unnecessarily used also. And most important, the availability of over-the-counter. The higher end antibiotics, even the novel agents in some places are available over the counter. So naturally, it increases the exposure risk. Development of resistance. We are dealing with a lot of high ESBL, CRE, and CRAB in the tertiary care ICUs. And fluoroquinolone resistance is also common in enterobacterials. And of course, the rates, there is a lot of heterogeneity because the rates of these resistance, these patterns, they vary by hospital, ICUs, as well as the specimen type. So, you cannot have a national number replace your local antibiogram. So, whenever you're thinking of AMR, you always have to keep the stewardship and your local antibiogram always in your mind. Now, what pushes us to start the antibiotic? When you have a critically ill patient who's in shock, multi-organ dysfunction, you have this fear of delay that if you don't start antibiotic, you're just going to increase the patient's morbidity and mortality. You are dealing with a patient who has a prior history of MDR colonization or has been hospitalized for a very long time. There are long-standing devices, he's been on the ventilator for a long time as an immunocompromised host, or there has been a recent use of antibiotics. Now, this is something which would tell you that you want to start quickly. But if you have started, then you should also keep in mind when to stop. When you get your negative cultures, when you have non-diagnostic cultures, your patient is improving clinically. Or you actually end up finding a non-infectious alternative diagnosis. And if you have started a cover, you've achieved good source control, the patient has got better, and the duration of treatment is completed. So there is no need to unnecessarily keep continuing the course of antibiotic. You must stop it then. So when we look at the global averages versus the Indian ICU reality, as you can see in the table, the ESBL E. coli, it is in India, it is often much higher. For the carbapenem resistance Klebsiella, we are dealing with a lot of OXA 48 and NDM, and which have become very important. For CRAB, there is often extreme resistance, so sulbactam based strategy becomes your mainstay. For MRSA, it is not that it's not prevalent, but it is very center dependent. And for fluoroquinolone resistant enterobacterials, again it is very frequently high in the Indian ICUs. So you need to understand that there is a global average which is there, and there is an Indian ICU prevalence. So you need, when you're thinking of your empirical cover, you have to have all these factors in mind about the resistance. So, what would your stewardship cycle actually involve or include? First of all, recognizing the syndrome and the severity of infection, sampling appropriately from the site of infection before initiation of antibiotics if it's feasible. However, do not delay therapy just to obtain samples. Giving appropriately timely empiric therapy matched with your local antibiogram. Then focusing, reviewing your cultures once they are available at 48 to 72 hours, and appropriately stopping, narrowing down or de-escalating depending upon the availability of your culture and response to treatment. So just to revise the 2020-26 surviving sepsis, the antibiotic timing. In shock and probable definitive sepsis, you administer antimicrobials within the first 1 hour ideally. You collect cultures as soon as possible, blood cultures as soon as possible, ideally before therapy. But like I said, do not postpone urgent therapy for prolonged diagnostic workup. In possible sepsis without shock, rapid time limited investigation is appropriate. If concern for infection persists, give antimicrobials within 3 hours. And of course, if the likelihood of infection is low, defer antibiotics with close monitoring. So, for diagnostic stewardship, it starts before the first dose. Like we were just talking about sending the samples. So, what do? You send two appropriate blood cultures, 2 sets, minimum 10 ml of sample. And when you're dealing with a specific syndrome, you have to collect the sample from that site of infection. Teach your staff to label correctly the source and the time at which they have drawn the sample. You do not treat you do not culture every colonized device or a non-sterile site without a syndrome. And treat just because a PCR and a resistance gene has come and there is no clinical syndrome associated with it, just based on that PCR, you start escalating or adding antibiotics. Don't do that. You must correlate it to the clinical syndrome. And using biomarkers alone. So biomarkers should not be used alone to decide the initiation or your empiric cover or whether the infection is present or absent. So the ICU specific antibiogram is the key. How? What do? You stratify by ICU versus ward, because hospital wide averages can often be misleading. Something which is more prevalent in the ICU may not be same in the ward. And wherever possible, you must separate infection syndromes. Avoid duplicate isolates from the same patient. And use your antibiogram for initiation of your empiric therapy. And once you have your AST available, you individualize and you select your definitive therapy based on the AST. So, as per the 2020-26 IDSA antimicrobial resistance, what should your empiric therapy be based on? Based on the patient history, if there is any prior isolation of organisms and AST, but you look back up to 12 months, any recent antibiotic exposure, especially in the preceding 3 months. Site of infection, illness, severity and immune status and organ function should always be kept in mind. And source control, don't forget that. And when you're selecting a drug, it should penetrate your site of infection. And of course, the local epidemiology and cumulative AST. So at 48 to 72 hours, what do? How do you select your antibiotic timeout? Again, are you dealing with infection? You recheck your diagnosis. Are you dealing with a non-infectious mimic? If you are dealing with infection, is the source controlled? Have you removed that infected line, or have you drained that collection? The organism that you grew and the empiric therapy that you selected correlated with your AST, and see that the antibiotic is appropriate. Now, after your AST is available, decide, can you narrow down that gram positive or that anaerobic coverage that you added initially? Can you stop that now? Can you de-escalate? Is the patient responding to the therapy that you started, or do you need to change? So all this basically helps you decide at 48 to 72 hours how to narrow down and de-escalate. So we were just talking about de-escalation. So it's a treatment decision, right? So you narrow the spectrum when you have a confirmed microbiological diagnosis. For anaerobic, you should not duplicate the anaerobic or gram-positive coverage when it's no longer justified. De-escalate even after an initial appropriate broad spectrum initiation. And if cultures are negative, reassess the possibility of infection and source control. So what should be the ideal duration of treatment? When you're dealing with CAP, generally when the patient is becoming stable, 5 days of therapy is enough. When the patient has HAP or VAP, 7 days, provided you're getting an adequate response and there is no uncontrolled source of infection. Uncomplicated gram-negative bacteria, 7 days is generally enough, provided the patient is stable, the source is controlled. Complicated intra-abdominal infections after source control, that is important, 4 days. Then skin and soft tissue, 5 to 7 days, depending upon the clinical response. So I've been talking about the PK, PD and the optimization. Just to summarize why it is important, because when you're dealing with critical illness, the loading dose because of capillary leak and the volume of distribution increasing for hydrophilic drugs, so loading dose is basically driven by the volume of distribution, not by the maintenance renal dosing. Again, just to re-emphasize, do not modify your loading dose based on the patient's renal function. That is something that you must remember. Prolonged infusion. Even the 2026 Surviving Sepsis campaign recommends prolonged beta-lactam maintenance infusion after a loading dose. And therapeutic drug monitoring is useful wherever it's available. After the optimization and understanding the basics and the de-escalation, another step of stewardship is IV to oral step down. When do you step down to oral therapy? When your pathogen is susceptible to the suitable oral agent that you're thinking of, the patient is improving clinically and is hemodynamically stable, the drug reaches adequate concentrations at the site of infection, There is appropriate gastrointestinal absorption of the drug. And one thing to remember is that for fluoroquinolones and trimethoprim sulfamethoxazole, do not use them as a step down without a confirmed susceptibility, especially when you're dealing with high resistance for that particular patient. A word about rapid diagnostics, because we're talking about stewardship. Now, rapid diagnostics, they have the advantage that they shorten your time to organism identification and they help you in initiation of early targeted therapy. But remember that they do not replace the full phenotypic AST. So you must always send your cultures and AST for all your patients. For biomarkers, even the 2026 Surviving Sepsis campaign now suggests that clinical evaluation alone is enough, and you do not need procalcitonin plus clinical evaluation to decide the initiation. And remember something about these biomarkers, that a single value is never specific for a bacterial infection. So you need to use trends with the whole syndrome and never a single number in isolation. And it is generally helpful for de-escalation or discontinuation. For infection prevention as a part of stewardship, for preventing transmission, remember hand hygiene still remains one of the most important steps. And of course, contact precautions wherever they are indicated, environmental cleaning and dedicated equipment and device bundles, and removal of your lines and tubes whenever they are no longer needed. So when we look at the program architecture, you need to have people who are accountable for the stewardship program. You need to have a leadership commitment. You need to be coordinated with your microbiology and your infection control team. You need to have a proper pre-authorization, a prospective audit and feedback structure, a daily ICU timeout in place. And what do you measure when you have this program, an antimicrobial stewardship program in your hospital? You measure the duration of therapy per 1,000 patient days, whether the stewardship program is adhering to the guidelines, whether appropriate de-escalation and appropriate duration of treatment is being carried out or not, and what is the resistance pattern and the hospital-acquired infection outcomes. That is what it should all include in the antimicrobial stewardship program in your hospital. So about the novel agents, they require syndrome definition, recent cultures, prior antibiotic exposure, and current AST and molecular data. You always have to prefer a mechanism-directed therapy for carbapenem resistance Enterobacteriaceae, the serine carbapenemase and the MBLs. If you have started, you review every agent at 24 to 48 hours, and you just simply stop, or you can de-escalate as soon as you have the susceptibility and source control. Very, very important, because these are the only drugs which are available and we still need to fence them. Since we are talking about the novel agents, when we have ESBL Enterobacteriaceae, and the international evidence tells us that carbapenems remain the preferred severe ESBL are the preferred drug for severe ESBL Enterobacteriaceae invasive infection. Avoid piptazo for severe ESBL bloodstream infection when carbapenem therapy is indicated. In India, we do deal with a lot of ESBL, especially in the tertiary care ICUs. So you must use your local antibiogram and the recent patient microbiology to avoid both under and unnecessarily carbapenem use. For CRE, we know for KPC and OXA48 we have ceftazidime avibactam. For MBLs, we have the Astronam avibactam strategy. So, rapid carbapenemase typing can prevent both the delay and unnecessary combination therapy. For difficult to treat resistance to Pseudomonas, if a traditional beta-lactam is active, you optimize the exposure with high dose extended infusion, and you do not label every carbapenem resistant isolate as difficult to treat resistant. And you use AST in infection site to choose the narrowest effective drug. If you are dealing with a true difficult to treat, then test the newer beta-lactams. So in India, we use ceftazidime avibactam. However, if you have ceftriaxone available, that becomes the appropriate choice. It again depends upon the local susceptibility and prior exposure. And very important, avoid automatic polymyxin use. when you have safer alternatives available. For crab, it is always, we all know that it can colonize the respiratory secretions. So you only treat when you have a compatible invasive syndrome. The mainstay of treatment is sulbactam backbone with sulbactam durlobactam. In India, we use high dose ampisulbactam. And you add a second agent depending upon the AST, the site of infection, the toxicity, and if there is and the toxicity profile. So, what should the ICU stewardship dashboard measure? What should it give you? It should give you the it should have practices in place wherein you send cultures before antibiotics. You should have proper guideline adherence systems. It should be able to give you the total duration of treatment, carbapenem duration of treatment, novel agent duration of treatment per 1000 patient days, de-escalation rate, median duration, IV to oral conversion, mortality, readmission, C. difficile rates and drug toxicity, and unit antibiogram trends and device associated infection rates. So this is what was about the stewardship. The next part of the module was on intra-abdominal infections. And for the intra-abdominal infections, we know that it is one of the major causes of surgical sepsis and ICU deterioration. And in India, we generally see more of perforated peptic ulcer, appendicitis, enteric perforation, abdominal TB, and abscess. So understand one thing, delay in source control can even delay fully active antibiotics. Very important for intra-abdominal infections, but very important for any other infection as well. And of course, the host severity and healthcare exposure determine the resistance risk. Now, you need to know what is an uncomplicated and a complicated intra-abdominal infection. So, in an uncomplicated infection, inflammation remains within the wall of the affected viscus. There is no extension into the peritoneal space or any other sterile abdominal compartment. So, a definitive procedure may eliminate the need for prolonged post-operative antibiotics. A complicated intra-abdominal infection is that extends beyond the viscus into the peritoneal space or on the sterile abdominal site. It may produce a localized abscess or diffuse peritonitis, and even in a complicated, usually requires source control plus a systemic antimicrobial therapy. But once you have achieved source control, generally the therapy can be shortened term. So how do you risk stratify the intra-abdominal infections? When you have a patient who's come from the community and has a lower risk, would have probably a stable pathology, no major MDR risk, and in such patients, from source control is feasible. For a patient with community-acquired high severity, would be like somebody who's come with organ dysfunction, is in shock, has major comorbidity, or is an immunosuppressed host. There is prior history of resistant organisms or antibiotic exposure. And healthcare associated would be post-operative leak, prolonged admission, or devices in situ, recent use of broad-spectrum antibiotics. There are scoring systems. So, risk stratification is important for complicated intra-abdominal infections, and generally Apache 2 is the preferred score. The WSES sepsis severity score is an acceptable alternative, but remember one thing, scoring only supplements. It never replaces your clinical judgment and your source control assessment. When we are dealing with infections in India, you have to keep the tropical spectrum in mind. So, perforated peptic ulcer is one of the prominent complications with intra-abdominal infections. Enteric fever, perforation, and abdominal TB in endemic settings. Amoebic liver abscess is regionally important. So this is just to emphasize that when you have a Western disease frequency list, don't use it and import it to your local epidemiology. You must remember that we are in India and we have to correlate it to our epidemiology. So typically, what sort of infections do we have? What sort of bugs cause intra-abdominal infections? Amongst the gram negatives, we have E. coli, Klebsiella, Enterobacterales, Pseudomonas. In gram positives, Strep and Enterococcus are the most relevant ones. For anaerobes and fungi, bacteroids and Candida, mostly in the high-risk healthcare associated settings. So like I said, source control is the backbone. So you need to drain that pus or infected fluid, repair or resect a perforated viscus when indicated, control that anastomotically, relieve the biliary or urinary obstruction, remove infected or non-viable tissue when necessary. Very important for intra-abdominal infections. So, what would your sepsis source control sequence look like? First of all, recognize, identify a specific anatomical source that requires an intervention. While you are, planning for the source control, you stabilize, you resuscitate your patient. You image, and the image should be the fastest and the most reliable modality, which will help you change your management. And source control, ideally within the first 6 hours. And reassess. When do you reassess? If your patient is deteriorating and if you need to relook at your source control. Then what is the imaging that you do for your patients? For an adult suspected appendicitis, usually CT abdomen and IV contrast is usually appropriate if it can be done. In pregnancy with appendicitis, ultrasound and MRI. Adult cholecystitis, cholangitis, ultrasound, but you need to integrate clinical and lab findings as well along with your image findings called cholecystitis and cholangitis. Adult diverticulitis, CT abdomen, and adult intra-abdominal abscesses, CT abdomen, as IV contrast can improve abscess wall visualization.
Okay, thank you.
So when you send blood cultures in suspected intra-abdominal infections, naturally when you're dealing with a sick patient who presents with symptoms of fever, is hemodynamically unstable, tachypneic, or is maybe delirious, when you have a concern that you might be dealing with resistant organisms, or you have a healthcare associated disease, an immunocompromised host, a patient with significant morbidity or recent antibiotic use. When do you send intra-abdominal fluid cultures? They are recommended when the patient is, there is a complicated intra-abdominal undergoing source control procedure, healthcare or associated or recurrent infections, immunocompromised host or high MDR risk, and when failure or recurrence would make targeted therapy important. So the empiric antibiotic selection would depend upon the source, whether it's upper GI, biliary or post-operative abscess, the severity, whether the patient is stable or unstable, is in shock, organ dysfunction, exposure risk, any prior hospitalization or antibiotic use, any risk of resistance, what does your local antibiogram tell you, any prior ESBL or CRE in the history, does the patient require an additional cover for gram-positive, MRSA or antifungal? And then source control. Can the source be controlled at that time of selection? For community-acquired intra-abdominal infection, how do you choose the treatment? So when there is a lower risk, you choose a regimen which is active against enterobacterials and anaerobes. Commonly, beta-lactam inhibitors are enough. And generally, you do not require MRSA, enterococcus or Candida cover in low-risk community-acquired. High-risk community-acquired would be a patient who's, we've just talked about, in shock, immunosuppressed, recent antibiotic. So a carbapenem may be appropriate where ESBL probability is high. For healthcare-associated intra-abdominal infections, you're naturally dealing with more resistant enterobacterials, maybe including CRE, Pseudomonas and other non-fermenters, enterococcus, especially in post-operative or high-risk settings, and Candida with recurrent abdominal events or prolonged broad-spectrum exposure. So for ESBL, for severe invasive ESBL infection, carbapenem therapy remains a dependable standard. Carbapenem sparing beta-lactam or beta-lactam inhibitor becomes your choice, which require reliable local susceptibility and appropriate syndrome. When do you add an extra cover? First of all, don't add it without a proper reason. You add an enterococcus cover when you have, especially when you're dealing with a healthcare associated disease, an immunosuppressed or prior cephalosporin exposure. For MRSA, if there is a prior MRSA colonization or in an infection which is compatible. And for anaerobes, one reliable anaerobic coverage is enough. You should not duplicate the anaerobic coverage.
9 week, 12 week.
Candida and intra-abdominal infection, the risk rises when there is history of recurrent GI perforation and anastomotic leak, prolonged broad-spectrum antibiotics and hospitalization, immunosuppression, malignancy or septic shock, or Candida is recovered from a fresh intra-abdominal specimen. For biliary infection, antibiotics plus drainage when there is an obstruction. So in case of cholecystitis, I just told you ultrasound is the preferred initial imaging. Early definitive surgical strategy according to severity and operability. Avoid prolonged antibiotics after you've achieved adequate source control, especially in uncomplicated disease. For cholangitis, the diagnosis obviously integrates systemic inflammation, cholestasis and imaging. Urgent biliary decompression is central, especially when there is obstruction, and blood cultures are useful when you're dealing with bacteremia or sepsis. For liver abscess, pyogenic, you generally have infection with enteric gram negatives, strep and anthrobes. You obtain cultures and you send the aspirate or drainage culture when the drainage fluid for culture when it is performed. You perform drainage for patients who have larger collections, multilocular collections, or they're poorly responding. For amoebic, generally, Antimibia histolytica remains the most important organism, and tissue amoebicide should be followed by a luminal agent. And for amoebic, you drain very selectively only when there is a large left lobe or there is a poor response or if there is a diagnostic uncertainty. Spontaneous bacterial peritonitis. The diagnosis is based on the criteria that ascitic polymorphonuclear neutrophils are more than 250 cells per millimeter cube, which is the treatment threshold, even with a negative culture. You inoculate ascitic fluid directly onto the blood culture, and you must always look for secondary peritonitis. For the treatment, you start appropriate IV therapy as soon as possible, and you must give albumin in patients who meet the renal or bilirubin risk criteria. For neutropenic enterocolitis, you recognize it when there is a profound neutropenia, patient has fever and abdominal pain, and CT often shows cecal or ascending colon wall thickening because blood cultures may still be negative. So diagnosis for neutropenic enterocolitis is clinico-radiological, and treatment is with immediate broad anti-pseudomonal therapy. And you avoid unnecessarily everything at once. Don't focus on a regimen that covers this everything together. And surgery is reserved for perforation, uncontrolled bleeding, or deterioration. Infected necrotizing pancreatitis, we all understand that no prophylactic antibiotics for sterile necrosis or severe pancreatitis. Early fever or SARS in the first week does not automatically mean that you're dealing with infected necrosis and pancreatitis. Infection in pancreatitis is likely when your patient may have gas in a necrotic collection. So you use the drugs that penetrate the necrotic pancreatic tissue. And you prefer a delayed, minimally invasive step-up approach when the patient can be stabilized. Duration after source control. So when you have an adequate source control in a complicated intra-abdominal infection, 4 days is sufficient for most patients who are improving. For uncomplicated perforation repaired early or uncomplicated appendicitis, generally very short post-operative course is enough. For bacteremia with uncontrolled abdominal source, 7 days if the patient is clinically stable. Inadequate or uncertain source control, you do not simply extend the therapy because the patient is not, you do not have you do not know the certain source. You reassess the anatomy if your patient is not improving or you feel that there is an inadequate source. And if there is no clinical improvement by day 4 or 7, you repeat diagnostic evaluation. Search for your missed source, or you might be dealing with a non-infectious mimic. That should always be kept in mind. So what do you do when your intra-abdominal infection is not improving? Like I said, always recheck the diagnosis. See if you might be dealing with a mimic. Are you really dealing with an infection? Re-image, look for that undrained abscess or that collection or that obstruction. Review source control. Look at your microbiology. Send a fresh specimen if needed. And optimize therapy depending upon the site of infection. And stop adding drugs blindly just because your patient is not improving. You need to revisit the anatomy. You because if you don't and you just escalate the antibiotics, you're naturally increasing the risk of antimicrobial resistance and of course increasing the risk of toxicity for your patient. So the take home message would be that you must understand the difference between complicated and uncomplicated intra-abdominal infection. You should use the right imaging depending upon the site of infection that you're dealing with. Obtain blood cultures selectively and fresh intra-abdominal cultures when complicated intra-abdominal infection undergoes source control. And we all understand that source control is the backbone, and choose empiric therapy from local epidemiology and then narrow quickly and use short course treatment after adequate source control. So the final take home message is start right, understand what syndrome you're dealing with, the severity of infection, how is your patient, what does he have any other associated comorbidities or as an immunosuppressed host, what does your local epidemiology tell you, cultures before therapy when feasible, timely active treatment in shock, do not delay therapy just to send your diagnostic samples. Always control the source, drain, debride, remove, and decompress. Use imaging to answer an intervention question and reassess anatomy always before escalating antibiotics in a non responder. At 48 to 72 hours, review the response to treatment, de escalate, narrow down based on the AST and your culture sensitivity report, and shorten the duration of therapy after source control. Thank you.
Thank you, Dr. Kanksha, for giving a recap of the last module in detail. And now we start the today's proceeding. And I have a great pleasure in inviting Dr. Professor Anant Mohan moderate the today's session, who is, I think most of you may be knowing him very well. He is currently the professor and head department of pulmonary critical care and sleep medicine at All India Institute of Medical College, All India Institute of Medical Sciences, New Delhi. He is a fellow of the Royal College of Physicians since May 2015. He is also fellow of the National Academy of Medical Sciences since January 2016. Member Indian International Association for Study of Lung Cancer and Indian Association for Study of Lung Cancer. He has been organizing in Padmokrit every year since 2012. He's achieved a lot of awards and his great achievements, UK Commonwealth Fellowship as International Clinical Fellow in International Pulmonology at Royal Preston Hospital, Lancashire, UK. Visiting Professor, Division of Lung Transplant, Temple University Hospital, Philadelphia, 2022. He is also the Honorary Professor of Respiratory Medicine, University College London. He has more than 350 publications, book chapters. He is also the editor of a book, Post-COVID Complication Management, and Associate Editor of Lung India. He has number of projects which are going on, and he has already guided a lot of projects. Over to Dr. Anant Mohan to conduct today's proceeding.
Thank you very much. Thank you very much sir, for the kind words. I think again, thank you for this opportunity on a very important topic. Basically, this symposium today is going to be on exacerbations, bronchiectasis, and aspiration syndromes, a very, very important entity that we are going to face almost on a daily basis in our practice. And for that, we have two extremely eminent speakers today. I think none of them actually need any introduction, but still, it's my duty. The first talk will be by Professor Randeep Guleria, and I think we all know him, and I myself am fortunate to be associated with him for the last 20-25 years actually. So Dr. Guleria is, he was earlier the Professor of Medicine at AIMS Delhi. Then he became the professor and head of the Department of Pulmonary Medicine there when it was established. Then went on to become the director of the institute for more than 5 years. That included the very challenging COVID period. And now he is the chairman of the Department of Respiratory and Sleep Medicine at Medanta Medicity, Gurugram. About his achievements and awards, I think again there is a long list, and I'm not going into that except for the fact that he has been a BC Roy National Awardee in 2014 and the Padma Shri in 2015. That is the two key achievements, and is more than 400 research publications. He is part of several international policy bodies. So I think without spending any more time on this, I'll straight away invite Dr. Guleria to deliver his talk today. Please.
Thank you, Anand, for your kind words, and I'd like to start by thanking Dr. Chawla and Akanksha for inviting me and for holding this CRCCID webinars. Let me see if I can share my slide. And
ರಿಲೀಫ್ ಇದೆ ಅಂತ ನೋವು ಏನಿಲ್ಲ ಅಂತ ಈ ಮಾತ್ರ ಈ ಆಯಿಂಟ್ಮೆಂಟ್
and this is the 18th module, if I'm not mistaken.
Correct.
So I think this is a tremendous effort that they have undergone, and I'm going to talk on something very basic. So from the wrap up that Akanksha gave of high-end antibiotics being used, we're going to really look at how can we rationalize the antibiotic use in our patients with COPD and asthma exacerbation, because somehow that is something that is not done as much as we should. So we have usually a 68-year-old man with severe COPD, 3 exacerbations in the last year. He comes to 2 days, increased dyspnea, cough and sputum volume. Sputum now, he says, is yellowish green. There's no focal chest pain. Saturation is 90% in room air. He's afebrile, hemodynamically stable. The reflex question that happens is, should I give this patient antibiotics or not? What additional information would change your threshold of getting antibiotics? Should you really send a sputum culture, or can you treat empirically? And does the yellow color of the sputum actually look equal to bacterial infection, and is that enough for us to start antibiotics in these patients who present with us to us with acute exacerbation of COPD? So if you look at COPD and asthma and exacerbation, these are major drivers of respiratory morbidity, ICU admissions and mortality worldwide. But it's important to remember that despite what we know, viral infections and environmental triggers dominate, and there is now more and more data suggesting that secondary bacterial infections remain a concern in COPD, but it's not that much of a concern when you have acute exacerbation of asthma. But by default, all of us automatically start broad spectrum antibiotics for every exacerbation, whether it be COPD or asthma, without really asking ourselves, does this patient actually need an antibiotic or not? And there is data now globally which suggests that this is one factor which is also driving antimicrobial resistance. So if you look at pathophysiology of acute exacerbation of COPD, one should understand there are multiple triggers. You have air pollution, you have environmental factors, then you have viruses and then bacteria. All of these then lead to cytokine production, they lead to various inflammatory markers coming up, chemokines. All of these lead to airway inflammation. And this leads to multiple pathways which are stimulated, and these could be neutrophilic driven, eosinophilic driven, they could be macrophages, and a large number of inflammatory cells enter the airways, the alveoli, and this leads to harmful effects which could have cardiovascular mortality, which we are recognizing more and more, that this can be a major cause of morbidity and mortality as far as exacerbation of COPD is concerned. They can be mucous hypersecretion, edema and bronchoconstriction, and of course this can later on lead to airflow limitation, increasing symptoms, and they could be symptoms of inflammation. So it is a cascade which starts, but it's not always that this cascade starts with bacterial infection, and that to treat this cascade at all times you don't need to give antibiotics. So the fundamental error that happens in overprescribing is clinical assumption is that every exacerbation is due to bacterial infection. In reality, if you look at it, COPD and asthma are actually two ends of different spectrums when you look at exacerbation. In COPD, you may have bacterial infection which may occur. It could be a contributor of exacerbation, but in asthma exacerbation or flares, it's not usually bacterial. It could be viral, it could be allergic, it could be inflammatory, it could be related to the environmental factors, and bacterial causes of exacerbation in asthma are relatively less common. If you look at acute exacerbation of COPD, and if you look at data, and this is a little bit old data, but this is something replicated in many other articles that two bacterial infection triggers are only in about 40 to 50% of exacerbation. That means half of the exacerbation that we see are not bacterial. They could be viral, and rhinovirus tends to dominate, but we also have influenza, RSV, adenovirus, and coronaviruses. And there could be atypical infection like chlamydia and mycoplasma, which can also cause a small number of cases. So remember, only about 40 to 50% of your exacerbations are bacterial in origin. This is a paper that we published with Dr. Anant Mohan. As a matter of fact, we did a study before this where we looked at viral infections in our emergency department using PCR-based RT-PCR, and almost 11 to 12% of patients who came to a tertiary care hospital, and remember these patients were coming almost after 10 to 12 days and being referred from other hospitals, had viral infection. But this data, our systemic review suggested that the weighted mean prevalence of respiratory viral infection was almost up to 34%. And picornaviruses, which is RSV, was the most commonly detected virus with around 17.3%, followed by influenza, respiratory syncytial virus, coronaviruses, parainfluenza viruses, and adenoviruses. Though it's important to remember that viral infections are common causes of exacerbation as far as COPD is concerned. Also, it's important to remember that when we look at exacerbation, you can also have non-infectious causes. Allergy, smoking, pollution, stress, all of these can cause exacerbation of COPD. Infections can be viral, atypical, and bacterial. So the point that one is trying to make is that all exacerbations really don't need aggressive antibiotics, and that is something that we need to understand. So I think So if you have an acute exacerbation, if you really want to look at rational use of antibiotic, you must really try and figure out, is this more likely to be viral or environmental triggers? Is there more inflammation and bronchospasm? Or is it a bacterial infection where potential antibiotics will be of benefit? And then only we should be able to take a decision that should I give antibiotics or not? Will there be any benefit of giving the antibiotic, or am I going to cause more harm? So the question in any exacerbation remains, should I give antibiotics or not? So antibiotic benefit in most studies has been shown to be strongest in the sickest patients. So if you have a patient who is in the ICU, he's sick, has multiple comorbidities, you could say that in these patients there is a definite role of giving antibiotics to treat, and it could be a bacterial infection. Purulent sputum may be a useful clinical symptom, but it's not synonymous with bacterial infection. We'll come to that. And repeated antibiotic courses actually leads to adverse effects, and it also leads to antimicrobial resistance. So I think it's very important to understand that should you give antibiotics to your patients exacerbating COPD in all patients or not. If you look at asthma, on the other hand, up to 80% of pediatric asthma and a large majority of adult exacerbation asthmas are actually viral, upper respiratory tract infection, allergens, or irritants. So they're not usually bacterial infection. It's basically a T2 driven inflammatory cascade that we see in most of our patients. 80% of our patients, some of them may have a neutrophilic driven or a T2 low exacerbation or drive. And you have IL4, IL5, IL13, which are the cytokines which are usually driving this. And these cytokines recruit and activate eosinophils. Neutrophils are usually seen in only if there's true bacterial infection. So there is a fundamental difference in the immune signature that we see in acute exacerbation of asthma as compared to acute exacerbation of COPD, where asthma exacerbations are mainly non-infective and don't need a lot of antibiotics. So asthma exacerbation, there's usually airway inflammation, bronchoconstriction, and antibiotic use usually not required. Treat the exacerbation, you give inhaled steroids, systemic inhaled bronchodilators, lava, you give systemic steroids when indicated, and oxygen if required. Antibiotics should be given if you're suspecting an underlying pneumonia and not for the asthma inflammation itself. Remember, this is an important feature to keep in mind. So one actually looks at what is known as a diagnostic fog when you have a patient who presents with a flare of asthma, wheeze, dyspnea, chest tightness, assess severity and look for infection. Is there any features to suggest a bacterial infection? Is there fever? Are there some focal signs to suggest a bacterial infection? Are there new infiltrates? Either do you find on examination there is crepitations or bronchial breathing, or you find a patch on the X-ray. If that is so, then you need to investigate and treat for bacterial infection. But if that is not there, then you need to treat it as a non-infective or non-bacterial cause of exacerbation. If you have a patient who has a severe or atypical presentation, you should also, of course, think of other causes like pulmonary embolism, pneumothorax, heart failure, anaphylaxis, foreign body, and of course, inducible laryngeal obstruction. So, asthma exacerbation should trigger the antibiotic question that asthma flare with wheeze, dyspnea, and reduced airflow is not by itself an indication of antibiotics. And I think I'm saying this repeatedly to drive home the fact because most of our colleagues will actually straight away start the patient on an antibiotics. Look for bacterial complication or for alternate diagnosis. Like I said, fever with focal findings, radiological infiltrates, pleuritic pain, crepitations, which may suggest that there is a bacterial syndrome. Also ask about viral symptoms. The patient has an upper respiratory catarrh, has classical features of an viral prodrome, then it's not necessary to give antibiotics. The viral prodrome may have caused the exacerbation and it may not be a bacterial infection unless you start suspecting a secondary bacterial infection, which can happen in some patients at a later stage. Do not use the sputum color alone as proof of bacterial infection. I think this is another important thing to keep in mind. So treating asthma exacerbation is basically you need to ask what can you do. You should assess the severity. You could do a pulse oximeter. If you're suspecting pneumonia, you can do a chest X-ray. If you want to see whether it's viral, depending on the season, and we are seeing a lot of viral infection during this time of the year, you could test accordingly using a nasopharyngeal swab and microbiology if you're suspecting bacterial infection. But routine cultures are not usually indicated in every asthma exacerbation. Routine procalcitonin is also not required. Routine antibiotics should not be given because the sputum is looking yellowish, and therefore one should look at broad spectrum treatment without a bacterial, should avoid using broad spectrum therapy without a bacterial target. Now, one often looks at the color and purulency of the sputum, and traditional teaching has been something like that. If you have thick yellow or green colored sputum, it's definitely a bacterial infection. Historically, this is looked at the bedside and a hallmark of bacterial infection, and this has triggered decades of antibiotic prescription in asthma patients. But actually, if you look at what is happening and if the sputum is examined, what happens is that eosinophil degranulation releases eosinophil peroxidase and pigmented granule proteins. This colors and thickens the sputum without any bacterial load. And it basically reflects allergy and viral eosinophilic inflammation rather than a bacterial infection. This is a non-infective cause. So don't really go by the color of the sputum as to justify giving antibiotic if you have other features which suggest that this is a non-bacterial cause of an acute exacerbation in asthma patients. We also use and have been using for a long time the very old Anthonesian criteria, the three cardinal symptoms that we use in any exacerbation of COPD, that is increasing dyspnea, worsening breathlessness beyond the patient's baseline, increasing sputum volume, a measurable rise in the daily sputum production, and increasing sputum purulence, which is supposed to be the single most predictive marker in COPD patients. And then you have type 1, type 2, type 3 criteria, which is basically takes a decision whether you should give antibiotics. If you have all three symptoms that I mentioned, then you should consider antibiotics. If you have only 2 or 3 of the symptoms but they include purulence, antibiotics are indicated only if purulence and dyspnea plus dyspnea or volume increase is there. If only one symptom, that is, if you go back, if there is basically only increased dyspnea or there's just only increased sputum volume, or the patient feels that there's just purulence of the sputum, antibiotics are just not usually not indicated. So Gold 2026 says antibiotics are uniformly indicated in acute exacerbating COPD patients with purulent sputum, positive prior sputum bacterium culture, or requiring mechanical ventilation, whether it be invasive or non-invasive. So keep that in mind. When we start treating our patients, the goal of antibiotic therapy in bacterial acute exacerbation of COPD is for rapid clinical resolution, complete bacterial eradication, resolution of airway and systemic inflammation, good quality life, and minimizing or making sure that there is more and more exacerbation-free intervals. So there is a need for looking at what we call antibiotic stewardship or stewardship checkpoints. Before starting antibiotics, is this bacterial, is there pneumonia, or is there another diagnosis? I think we should ask ourselves rather than reflexively starting antibiotics. Choose the narrowest regimen likely to cover the targeted pathogen. Reassess sputum, culture, oxygenation, and complication in terms of how the patient is responding. And if you find that the patient is responding, then you could stop, narrow, or de-escalate depending on what the evidence is there. Normally, when we look at antibiotic selection and we start starting empirical antibiotics, we cover the big three pathogens which are supposed to be causing most of the exacerbation, and that is Haemophilus influenza, Streptococcus pneumoniae, and Moraxella catarrhalis. These are the three that we need to cover when we start empirical therapy as far as acute exacerbation of COPD, which we could think is bacterial in nature. The aim is to cover this without causing a lot of damage to the host microbiome. And current guidelines actually advocate a truncated 5-day antibiotic course, and I'll come to that in subsequent slides. This has been proven to be non-inferior to longer courses. If you remember, we will remember that long time back we were taught that you need to give a 10 to 14-day course of antibiotics. That is no longer true, and that actually helps because it eases resistance pressure and reduces adverse effects. So, what is the empiric antibiotic choice? One is, I think, as we've been discussing in the previous talk, also use local guidance in antibiogram. So, you should know what is the local antibiogram in your area, what is the type of bugs that you see, what is the resistance pattern. And commonly, one gives an aminopenicillin or a beta-lactamase in a macrolide, and at times you could also give doxycycline depending on local resistance or patient factors. Oral therapy is usually preferred in clinical appropriate when there is a low risk. But when you have a high risk setting or a complicated setting, one must also evaluate whether there could be prior Pseudomonas infection or there could be resistant gram-negative isolation. This becomes more and more common if you have a patient who has recurrent exacerbation and is coming repeatedly to the hospital or being admitted. So frequent exacerbation, severe airflow limitation, recent antibiotics, or hospitalization or requirement of mechanical ventilation all put this patient into a high risk category or a complicated category where Pseudomonas or resistant gram-negative pathogens need to be covered. So you should obtain culture, tailor your therapy, and anti-Pseudomonas coverage should be considered, especially if you have a patient who may have underlying bronchiectasis or a structural lung disease which could lead to colonization with Pseudomonas. There have been a lot of studies, and this is a large study which is looking at broader spectrum. Does a broader spectrum antibiotic lead to better outcomes in acute exacerbation of COPD? Because that seems to be the common reflex action that we have, that let's give a broad spectrum even from mild to moderate exacerbation. So this is the data from the Danish Registry of COPD, which tested this assumption that should you give a broader spectrum in more than 45,000 patients. They reviewed their records. About 12,900 patients received only amoxicillin, but the vast majority, more than 30,000, received amoxicillin glipizide acid. But what they found was that standard amoxicillin was associated with lower risk of severe outcomes than amoxicillin. So it was not inferior in any way, and if you just gave amoxicillin in mild to moderate exacerbation of COPD, it was equally effective and it was actually associated with lower risk of severe outcomes, the hazard ratio being 0.6. So data does suggest that we don't really need to give a higher end antibiotics when it comes to mild to moderate exacerbating COPD. This is another paper, it's an old paper, but it is a meta-analysis of randomized controlled trial which looked at first line with second line antibiotics for acute exacerbation of chronic bronchitis. And this looked at the effectiveness and safety of antimicrobial agents. First line agents being amoxicillin, ampicillin, trimethoprim, sulfamethoxazole, ampicillin, which we don't use, and doxycycline. And second line antimicrobials like amoxicillin, clavulanic acid, macrolide, second generation or third generation cephalosporins, and also quinolines for the treatment of acute exacerbation of COPD. So although they found that first line antibiotics was associated with low treatment success compared to second line antibiotics in clinically evaluable patients, there was no difference among the compared regime regarding mortality or treatment success. So both the first line treatment, which is lower end antibiotics as compared to higher end antibiotics, were equally effective when it came to looking at mortality or treatment success. So again, an important message that you don't need to jump to very high end antibiotics when you are seeing a patient with mild to moderate exacerbation in your OPD. There's also another paper published which looked at macrolides, quinolines, and amoxicillin, clavulanic acid in chronic bronchitis, a meta-analysis. Again, there was no difference regarding treatment success in intention to treat between macrolides and quinolones, amoxicillin clonulanic acid and quinolone, or amoxicillin clonulanic acid and macrolides. So therefore, again, the message here is that there is really no advantage of giving high-end antibiotics in your patient with acute exacerbation of COPD unless you have a very sick patient, unless you have the risk factors which suggest that there could be resistant pathogens or the patient has more severe COPD. That is something we need to keep in mind. Coming to the duration of treatment, there is this meta-analysis which looked at short course antibiotic therapy to be as effective as standard course of COPD exacerbation. This is a systemic review and meta-analysis, and this found that short course antibiotics were not significantly different from those for long course treatment, which could be 7 to 10 days. So 5-day course is usually effective as far as treatment is concerned, and adverse effects were similar. There was slightly less in patients receiving short course treatment, 21% as compared to 22.8% in those receiving the standard long course treatment, and as you can see, there was no difference as far as the outcome was concerned. What the goal criteria says is that you must give antibiotics for 5 days or less in outpatient antibiotic treatment for COPD exacerbation. It could be given for up to 7 days in depending upon the severity and the response to treatment, but by and large 5 days treatment is enough. So remember, longer treatment is not consistent with better response, and it only should be indicated when it is you can justify why you want to give more than 7 days. There is a recent paper which is published from the GREAT network which looked at a 2-day versus 7-day course of levofloxacin in acute COPD exacerbation. This was a randomized controlled trial. It had more than 300 patients randomized into 2 arms. And again, they found that even a 2-day course of antibiotics in acute exacerbation of COPD was effective and was not associated with decrease in their cure rates. It was not inferior. There was no change as far as additional antibiotic requirement was concerned or hospital readmission was concerned. So they argued that their finding suggested that this could improve patient compliance because many patients in the OPD may not complete a 5-day course and reduce the incidence of bacterial resistance and adverse effect. So we are looking at more and more shorter duration of treatment rather than going to the traditional 10 to 14 days treatment for acute exacerbation of COPD. How do you select your antibiotics based on clinical criteria? One is to look whether the exacerbation is mild, moderate or severe, and we've already said you look at any one of the 3 cardinal symptoms: increased dyspnea, increased sputum volume, increased sputum purulence. If only one of the 3 is present, you usually don't need to give antibiotics. Increase your bronchodilators, give symptomatic therapy, and monitor the patients. If the patient has at least 2 of the 3 cardinal symptoms that we mentioned, then you try and assess whether this is complicated or uncomplicated COPD. And then you start looking at risk factors, the age of the patient, the FEV1, has he had previous exacerbation, is there cardiac comorbidities, any previous hospitalization in the last 12 months, is the patient on supplement oxygen, and based on that decide whether it's an uncomplicated or complicated case that you're dealing with as far as COPD is concerned. And then you could really decide on whether you want to give a macrolide, cephalosporin. If you have a higher risk of or if you have a complicated patient, then you could look at amoxicillin clonulanic acid. And if there is a risk of Pseudomonas infection, if we said, then anti-Pseudomonas antibiotic should be given. If you have a patient who is hospitalization, therefore he is likely to have moderate to severe exacerbation, again he would have at least 2 of the 3 cardinal symptoms and complicated COPD. You then assess for risk factors. Advanced COPD, previous isolation of Pseudomonas from the sputum, if there is associated bronchiectasis, previous administration of antibiotics within the last 3 months, hospitalization within the last 12 months, or there is systemic glucocorticoid use. If they are there, then you should look at that this patient may have risk for Pseudomonas, and then you need to start giving anti-Pseudomonas treatment. Could be ceftazidime, piperacin-tazobactam, or cefepime. Or if it is not there, you can even just give ceftriaxone. And then you of course monitor your patients for the response and then decide whether you need to further investigate or the patient is doing well. So this is putting it in another way, we're trying to combine everything. We look at the sputum. If it's mild, you just give bronchodilators and observe for 3 days. If it is moderate severity, then you look for whether the patient has severe underlying COPD with comorbidities, the age of the patient, history of exacerbation and respiratory failure, and then decide whether the patient can be treated in the outpatient and inpatient. If you're looking at an inpatient treatment, you would also evaluate for Pseudomonas risk, and based on that, decide on your antibiotic protocol that you would like to give. What about prophylactic macrolides? Now, if you look at the guidelines recommend that patients who are continue to have exacerbation and are not responding despite triple therapy, that is LAMA ICS, one can consider macrolides, and GOLD supports the use of azithromycin for frequent exacerbators, particularly former smokers, to prolong the exacerbation-free intervals. Remember, this is not from its own antibiotic point of view, but it's from the immunomodulator point of view. Macrolides have good immunomodulatory effect, and there is data which suggests that use of antibiotics can actually the rate of exacerbations per year comes down as far as these patients are concerned, and therefore there is a role in the select group of patients who continue to have exacerbation despite being on triple therapy to consider giving long-term macrolides. The next question comes is, should we use a biomarker in addition to our clinical judgment? Till now we've been discussing how do we treat these patients using your clinical judgment, the sputum, the purulence, the amount of sputum, the increase in dyspnea, or looking at comorbidities in the patient. So the criteria that we're using are symptom-based and are inherently subjective. Some patient may feel the sputum is more, some may not feel it very much, and there is a bias as far as patients are concerned. So there has been a lot of interest to see whether point of care biomarkers can really help us as far as our decision is concerned. And two biomarkers which have been studied a lot are CRP and procalcitonin. So we had this trial, the PACE trial, which looked at over 650 patients with acute exacerbation of COPD. They were randomized to usual care or point of care CRP guided treatment, and they looked at a CRP of less than 20 milligram per liter as bacterial infection unlikely and antibiotics were generally withheld. If it was between 20 to 40 milligram per liter, it was classified as indeterminate, and antibiotics were prescribed only if purulent sputum is documented, and CRP more than 40 milligram per liter, bacterial infection was high probable and antibiotics were prescribed. And this was how the study was conducted. What they found that in the first arm, which was CRP guided, there was antibiotic use was 57% as compared to 77% with antibiotics were given as part of usual care, and odds ratio for antibiotic use was 0.31. So there was a 20-point reduction achieved with no compromise in recovery, quality of life scores, hospitalization, or 6-month mortality. So CRP at times may help us as far as treatment strategies concerned. We had the bacteria trial, which is looked at procalcitonin, and this was looking at patients experiencing acute exacerbation of COPD. These are basically assigned to antibiotic therapy was guided by a 5-day procalcitonin algorithm for initiation and stoppage of antibiotics, or this was compared with standard guidelines. And the primary endpoint was 3 months mortality. The PCT group failed to demonstrate non-inferiority with respect to 3-month mortality and failed to reduce ICU or in-hospital antibiotic exposure for acute exacerbation of COPD patients admitted in the ICU. So procalcitonin did not really help us in deciding as far as antibiotic therapy is concerned. So the PROACT trial was another trial which looked at procalcitonin, and this was looked at the emergency patients who came to the emergency department, and patients suspected to have LRTI presenting to the emergency department were randomized to PCT guided versus usual care. There was no significant difference in the total antibiotic days, and this was a striking contrast to the PACE trial which I just showed you in a few slides before, which showed there was a sustained reduction in antibiotic use. So PCT really did not really have any difference in antibiotic days, although the previous study did show that. So why did the PCT trial fail to change the emergency department prescribing habits? I think one thing to understand is that when we have very sick patients in the emergency, we frequently overrule the low PCT values because we feel that the patient is unstable or at high risk, and therefore we don't give it that much of consideration. The treatment protocol also allowed overriding for hemodynamically unstable patients, life-threatening comorbidities, ICU admissions, severe illness scores, which to my mind to some extent was justified.
2.5
And we also have the fear of missing out on an occult sepsis which may not be picked up by a low PCT, and therefore one tends to give antibiotics even if your procalcitonin level is low. But the data did suggest that PCT was inherently safe without no significant mortality difference at 90 days. There is another data which is looked at by, this is looking at Philip Schutz, who has done a lot of work on procalcitonin guided antibiotic stewardship, and he developed a consensus statement. And his statement was basically looking at PCT and deciding whether to give antibiotics or not. It still needs, I think, in my mind, more data to really show that procalcitonin can help us to guide antibiotic treatment. I don't think we have reached that stage where we should look at procalcitonin alone as a guide as far as treatment starting antibiotics is concerned. De-escalation is something that is can be used when we start looking at procalcitonin. When we come to the GINA guideline, GINA clearly does not support extensive antibiotic use because it says asthma exacerbation defined by reversible bronchospasm, mucosal edema, and mucosal plugging. Primary bacterial infection is rare, and therefore antibiotics are usually not advocated as far as GINA guidelines are concerned. Here, eosinophils play a major role, and therefore, unlike CRP and PCT, blood eosinophilia helps us in deciding whether this is T2 driven inflammation and therefore whether we should look at more of anti-inflammatory and corticosteroids as far as treatment is concerned. So, an elevated blood eosinophilia usually predicts a good response to corticosteroids. A low eosinophilia with neutrophil predominant may actually predict little steroid benefit, and here you may actually think of whether you would need to give an antibiotic or not. The European Association of Allergy and Clinical Immunology came out with a position paper where they tried to answer, is there a beneficial effect of antibiotics on symptoms and hospitalization in patients who have asthma exacerbation. They did a systemic review, 9 RCTs were reviewed, and there was a Delphi procedure which was followed. The results that they came out was that the strong evidence for antibiotics in acute asthma exacerbation is scarce. Macrolides shorten the episode duration, but there is no clear evidence of antibiotics to be given in adults with asthma exacerbation, and antibiotics are usually associated with longer hospitalization. This was based on retrospective studies. So their recommendation was to avoid routine antibiotics in all acute exacerbation of asthma. So when are antibiotics justified in acute exacerbation? If you have high persistent fever with toxic and systemic appearances, radiological evidence of focal consolidation, crepitations on your on findings which suggest bronchial breathing, and then in the absence of these findings, antibiotics should not be considered. And there has been data which suggests that sometimes people prefer giving antibiotics rather than focusing more on bronchodilators and steroids, and I think this is very important that sometimes you don't give the classical therapy of giving budesonide, formoterol, rather than you just give antibiotics, and therefore in both mild to moderate exacerbation, the center should be bronchodilation, anti-inflammatory drugs, rather than giving a lot of antibiotics, and I think that is very, very important to keep in mind. In severe life-threatening exacerbation, where you have a patient whose saturation is low, who has a silent chest, who needs to be treated in acute emergency, again the focus is on oral steroids, nebulized bronchodilators, oxygen. Antibiotics may have some role, but they have a very limited role even in this situation. What about azithromycin in severe asthma? The AMAZE trial, which was a double-blind, placebo-controlled, randomized trial for 20 patients with severe asthma, showed that there was some role as far as macrolides were concerned, from the point of view that it's given subsequently in these patients, despite being on ICS LAVA, did lead to decrease in the subsequent chances of severe exacerbation. It fell from 61% to 44%, and if it was affected in both eosinophilic and non-eosinophilic severe asthma. So there may be a role of looking at macrolides as a long-term strategy in patients who are having recurrent exacerbation as far as asthma is concerned. Long time back, we did a study of our asthma who were having poor control, and even when they did not have features of acute exacerbation, throat swabs we were able to show on throat swab that there was colonization by mycoplasma, and those subjects who had mycoplasma colonization were having more frequent asthma exacerbation, and we had proposed that this could be a trigger for asthma exacerbation, and these subset of patients would benefit for long-term macrolide use. So remember, antibiotics are not harmless. They can have side effects, they can cause ecological change, and they can also lead to unnecessary antibiotics can create false assurance and delay the actual treatment. So it's very important for us to be sure about rational use of antibiotics when it comes to acute exacerbation of COPD or asthma. So for COPD, you need a high precision calibration, bacterial infection. If it is genuine, you must take a call and then look at the Anthonian criteria. You could use the point of care CRP. 5-day course is enough, and you must look at lower end antibiotics rather than jumping to higher end antibiotics. For asthma, it's usually viral or allergic. Don't need to give antibiotics. And remember, in asthma, the yellow color sputum is not infective. It could be because of eosinophilia, and you must focus more on bronchodilators, steroids rather than antibiotics. So I'd conclude by saying that you must look at rational prescribing as far as acute exacerbation of COPD and asthma is concerned. In COPD, reserve antibiotics. For Anthonian type 1 or severe or hospitalized disease, you could use CRP to reduce inappropriate antibiotics, especially in a primary care or outpatient setting. In asthma, bronchodilators and corticosteroids are the first line. Always antibiotics only if there's proven bacterial infection, and sputum purulence alone is never a valid marker for infection as far as asthma is concerned. So I'll stop here and thank you very much for patiently.
Thank you very much, Dr. Gloria, giving us a very comprehensive and at the same time a very evidence-based overview of how to deal with antibiotics in our two important exacerbation conditions, asthma and COPD. I think the importance of giving it and also the importance of not giving it, and also when are the situations where we should use. So I think as per the format, we'll have questions at the end of the two talks. So right now, I think I'll immediately call upon the next speaker for the day, or rather the evening, and that is Dr. Vivek Nankia. Dr. Vivek Nankia also is a very experienced, very well-known personality in the field of respiratory medicine. He is the Vice Chairman of the Department of Pulmonary Critical Care and Sleep Medicine at Max Hospital, Saket. He has several important positions of responsibility to his credit. Apart from more than 25-30 years of experience in clinical and research work, he has been the Vice President of the Indian Association of Bronchology. He has been trained in infectious diseases from London University, has several publications to his credit, including best articles in the IAB. Also has been awarded extensively, and one of them the icon of respiratory medicine by the Indian Medical Association a couple of years back. Research awards by the NAPCONs. He has been member and chairman of several societies, both national and international, which are policy making and making guidelines for several respiratory medicine procedures and diseases. He's also a very strong advocate of antimicrobial resistance, which is a very important topic these days, and rightly so, and also on adult immunization. So I'll call upon him to speak on the other topic of the day, which is bronchiectasis and aspiration syndromes. So Dr. Vivek, please.
Thank you, Dr. Anand, for such an illustrious introduction and for all your kind words. And thank you, Dr. Chawla, for inviting me to this prestigious platform. Can I have the provision of sharing slides? Right now, I'm not able to share my slides. Can I be authorized to share my slides?
Soumitra? Soumitra? You try. This has never been a problem.
So now I am, yes. G, thank you. So I have been assigned the task of tackling two infections today, bronchiectasis and aspiration syndrome. Both are very vast and very extensive, but I'm going to try and focus only on the infection bit and not go beyond that. So bronchiectasis basically was considered to be an orphan disease at one time, but now is recognized to be quite common. And this has started happening primarily because of the invention of the CT scanner, which is now able to pick up even the small little changes in the lungs that are visible on the CT. So from 2003 to 2013, it has increased by almost 40% to 566 per 100,000 people globally. If we look at the Indian data, there is this embark registry that was conducted sometime back between 2015 and 2017. 2,000 plus adults were confirmed to have a CT proven bronchiectasis. The median age was 56 years. But what I want to highlight here was that most of these bronchiectasis that we saw in India were either post-tuberculosis and the common infection that was seen was Pseudomonas, Klebsiella, H. influenza and NTM were found to be rare. They were usually cystic bronchiectasis involving the lower lobes and the right middle lobe most frequently. So what is bronchiectasis? Bronchiectasis is a permanent dilatation of the bronchi where there is loss of cilia, increased mucus production and destruction of the wall, because of which there is collection of phlegm inside. And there could be various reasons why it happens. One, of course, would be post-infectious, as I just discussed, especially when you have a necrotizing pneumonias in adults, measles, granulomatous infections. Then it could also be seen in primary immune disorders, cystic fibrosis, alpha-1 antitrypsin abnormalities, so many other heritable structural abnormalities. Apart from that, also seen in various idiopathic inflammatory disorders like sarcoidosis, RA, ankylosing spondylitis, SLE, Sjogren's syndrome, chronic recurrent inhalations of gastroesophageal aspirations, pneumonias, toxic inhalation, all these are known to cause bronchiectasis. RA, you can see it in almost 20 to 25% with respiratory symptoms. And ankylosing spondylitis is 1 to 2% of the cases would see in upper lobar predominant disease. IBD, ulcerative colitis, more than the Crohn's, is seen to be associated with bronchiectasis. Now, why does infection matter so much in patients with bronchiectasis? Basically, there's a chronic airway infection which drives the neutrophilic inflammation, resulting in mucus dysfunction and structural injury. Pseudomonas is the most common infection in these patients, and it's also the cause of frequent exacerbations, admissions, and mortality. Frequent exacerbations, as they suggest, would accelerate the morbidity and identify patients for preventive therapy. So, impaired mucociliary clearance results in mucus pooling, which then results in neutrophilic inflammation, which then results in airway remodeling, structural damage. So this is the kind of vicious vortex that goes on in a patient with bronchiectasis. This finally results in biofilm formation, excessive mucus, which the patient is unable to clear, resulting in persistent infection, airway obstruction, dilatation, oxidative stress, and hypoxia, ultimately damaging the airways extensively. Therefore, it is important to not just look at every isolate that you get from the sputum as a colonizer. We have to consider it as a chronic airway infection rather than assuming it to be a harmless colonization. The common bacteria are Pseudomonas, H. influenza, M. catarrhalis, Staph aureus, and Enterobacteriaceae is seen in selected patients. But as I showed you earlier also, it is important to consider NTM as a possibility, that is a non-tubercular mycobacteria or the atypical mycobacteria or mycobacteria other than tuberculosis. Aspergillus, ABPA are also commonly seen associated with bronchiectasis, and then there could be viral triggers as well. Therefore, it's important to interpret the culture in context of the symptoms, repeated isolations, bacterial densities, prior therapies, and radiology. But what is very important is that whenever the patient is either in a stable condition or during an exacerbation, one must check the sputum for the kind of bacteria that is growing inside. Especially if you're considering giving an antibiotic before an exacerbation, it is important to send a sputum sample. It's also important to get a mycobacterial cultures done when clinically indicated, and especially when you're planning long-term macrolide therapy, because macrolides are very effective drugs which are used in the management of NTM infections. If the patient is unable to bring up sputum and you want to consider giving long-term antibiotics, then of course bronchoscopy would be a choice to pull out the phlegm and see. There is a strong case here where patients should be given long-term antibiotics. The scientific rationale behind it is that there is a huge bacterial load which correlates very well with the airway and systemic inflammation and also with recurrent exacerbations. And antibiotics are known to reduce the bacterial load, the inflammatory markers, as well as the exacerbation frequency. So the empiric antibiotic choice would depend on the sputum bacteriology that you've had in the past, or depending on the resistance patterns. But it is important to cover the Pseudomonas, especially if it has been isolated in the past. Dr. Guleria was also talking about the antimicrobial stewardship principles. It's very important to use the narrowest effective agent and adjust to the culture if the patient is not improving or resistance patterns are something different and suggest a different antibiotic. Oral therapy, of course, is appropriate for many of these patients, but IV therapy could be used for severe illness, resistant organisms, as well as patients who fail on the initial oral therapy. Pseudomonas continues to be key pathogen. As you can understand, I've been highlighting it repeatedly. The prevalence is almost about 15% and only rising. It's associated with increased mortality, increased exacerbations, increased hospitalizations, and the odds ratio is anything between 2.03 to 2.95 for mortality with Pseudomonas infection. So chronic Pseudomonas infection basically is a high-risk phenotype which needs aggressive management. Macrolides have been recommended for its use. Azithromycin is one drug that we use quite often for these patients, which is given as 500 mg, 3 doses per week, and has been shown to reduce the exacerbation. Another study where they used 250 mg once a day, it showed reduction in exacerbations 0 versus 2. And erythromycin 250 mg twice a day has also been shown to reduce the exacerbations. So a large meta-analysis was conducted, which actually showed that there was a reduction in exacerbations by almost 50%. There was a small increase in FEV1. Of course, GI side effects were common, and there was a possibility of macrolide resistance to the tune of 27% in these patients. Yet, ERS 2025 strongly recommends the use of macrolides for patients at high risk of exacerbation despite all the standard care, and is shown to benefit across Pseudomonas, non-Pseudomonas, and culture-negative phenotypes as well. So the dose that they recommend is 250 mg daily or 3 times weekly, or 500 mg 3 times weekly, the standard dosage. But what is important is that before starting macrolide, you should check the ECG for any QT intervals, check the other medication that the patient may be receiving, liver functions, hearing history, because it can impact the hearing also at times. It is also important to assess the risk of NTM infections, therefore obtain a mycobacterial culture, because if the patient has an NTM and we start them on a monotherapy, then we're going to land the patient up into a problem. So we never use a macrolide monotherapy in active NTM cases, therefore it is important to rule that out completely. Then during therapy, one must be cautious about GI tolerance, risk of QT interval prolongation, hearing, liver toxicity, and microbiological ecology. It's important to reassess ongoing need and benefit periodically. And of course, the antimicrobial stewardship remains essential. There are also some non-macrolide antibiotics that have been used on a long-term basis, like ciprofloxacin and others, but ERS conditionally recommends against the routine use of these antibiotics. Evidence of sustained benefits is limited, and resistance adverse events may outweigh the benefit. Reserved for selected circumstances when preferred strategies are unsuitable, and there is no role of rotating oral antibiotics. Inhaled antibiotics bronchiectasis is one area where inhaled antibiotics seem to be working very well. Different antibiotics have been tried for this purpose. There are studies which have looked at ciprofloxacin in a DPI form, where it was given for 84 days with 28-day treatment and a follow-up in patients with more than 2 exacerbations. It was able to reduce the bacterial load, but there was no significant difference in proportion of patients with exacerbations and in the SGRQ. Ciprofloxacin DPI has been used in 2 other studies also, and similar results were seen in these patients as well, but it was well tolerated. In one of the studies, it also reduced the frequency of exacerbation. Liposomal ciprofloxacin is another drug which has been tried, especially in patients with Pseudomonas, which was patients colonized with Pseudomonas and more than 2 exacerbations in the previous 12 months. There was a significant reduction in Pseudomonas bacterial load that was seen, and reduced number of exacerbations also seen in the group which was receiving the active treatment. And there was no difference in the MICs to ciprofloxacin at day 28, and no increase in the adverse events. Apart from liposomal ciprofloxacin, Astronam is one other drug that has been tried. of 28-day treatment courses alternating with 28 days off treatment in patients with positive Pseudomonas or other gram-negative organisms, and no difference was seen in the quality of life at 4 weeks, with no difference in the quality of life in both studies at week 12 either, and no difference in time to first exacerbation. One common drug that we have also been using for very long is tobramycin. There are various studies that have been conducted with tobramycin in the nebulized form in patients with Pseudomonas where the bacterial load was tested, 6 weeks treatment, 28 days and then 28 days off, and there was a significant reduction in Pseudomonas load, significant reduction in exacerbations also that were noticed in this group of patients. Gentamicin and colistin, there are two other drugs which are used. Out of these, colistin is one drug which is extremely important and is used quite often these days because of the MDR Pseudomonas that we are isolating. So again, it is been shown to be beneficial in this group of patients in reducing the bacterial load as well as improving the time to first exacerbations in these patients. So a commonly used approach for patients colonized with Pseudomonas is a use of systemic anti-Pseudomonal therapy for about 14 days, followed by inhaled antibiotics for the next 3 months. Example that has been quoted in ERS is use of ciprofloxacin 750 mg twice daily for 14 days, followed by nebulized colistin twice daily for 3 months. Except that we prefer not to use any fluoroquinolones in pulmonology, primarily because they are very effective anti-tubercular drugs as well. So one would rather reserve them as MDR-TB drugs rather than use them here, unless you are pushed against the wall and you've safely ruled out that there's no underlying tuberculosis, then probably you could use it. If oral therapy is unsuitable or resistant, then IV Pseudomonal beta-lactams can be used along with aminoglycoside followed by inhalation therapy. And one must do a repeat sputum after treatment and longitudinally to document eradication or recurrence of the infection. How successful is eradication? This was looked at 12 months. A 2024 systematic review showed Pseudomonas negative in about 40% of the patients. Combined systemic plus inhaled therapy was what was used in these patients and resulted in 48% eradication versus 27% in only systemic therapy. Evidence is largely observational and regime has been heterogeneous in most of the cases. Despite imperfect success, guidelines direct towards using the eradication regime in these patients. Now, if we look at specific organisms, H influenza, if you're dealing with, then amoxiclav is a good option. MSSA, MRSA, accordingly, you'll have to use, for MSSA, flucloxacillin would be a good option. For MRSA, maybe injectable, but levonorephoxacin has turned out to be a good option. Enterobacteriaceae, then you'll have to go by the susceptibility testing and consider ESBL risks, especially in our kind of circumstances and where patients have received antibiotics in the past. NTM is something that should be suspected if there is nodular or clean bud appearance, cavities, weight loss, refractory symptoms, or repeated atypical being isolated. Diagnosis requires compatible clinical and radiological features. A single sputum sample growing positive for NTM is not sufficient. There should be at least 2 or 3 samples positive or a bronchoscopy sample positive for NTM before you start treatment. For macrolide susceptible MAC, guideline-based multi-drug therapy should be used, including a macrolide. A regime intensity depends on the cavitation and severity. Then ABPA is something that you must keep in mind. Difference in the initial phases itself. If there are big cavities or fungal wall developing, then we must look at chronic pulmonary aspergillosis as a possibility. But again, fungal culture positivity alone does not mandate antifungal therapy, provided there are consistent radiological features as well to suggest an active fungal infection. Viruses can also trigger exacerbations and may coexist with bacterial infection. Therefore, it is important to use the local data and local testing for viruses as and when required. Like these days, we're getting a lot of influenza patients as well as COVID-19 patients. So such patients, if they come in for exacerbation, must be tested for these viruses as well. Vaccination, of course, is always good, especially against influenza, pneumococcal, and COVID-19 diseases. But avoiding automatic antibiotic escalation when the clinical syndrome is convincingly viral should be considered in these patients. While dealing with exacerbations, one must realize that it could be a watershed event in these patients, could be associated with increased mortality, a faster lung decline, worse quality of life, and increased hospitalization. The mortality could be as high as 2 times as compared to a non-exacerbator. So 3 or more of the following symptoms should be kept in mind: coughing, increased sputum volumes, increased sputum purulence, breathlessness, fatigue, malaise, and hemoptysis. So if there is an exacerbation, it should be treated with an antibiotic. While in most situations you treat them for 5 to 7 days with antibiotic, but in this case, the outpatient department, you could 14 days of oral medication. But if it is a severe illness, then probably patient will require in-hospitalization, 14 days of IV medication or maybe home-based therapy if the trained nurse or management is possible at home. Surgical candidates are far and few because it can be only used in patients where it is localized disease, younger population, prolonged symptoms, frequent serious exacerbations, massive refractory hemoptysis. There are very small number of patients who are actually suitable candidates for it. There are no randomized controlled trials, but it goes without saying that if it's a localized disease, you get it operated, you're treating the patient for the rest of his life. There are newer drugs also that are now available. They are not like antibiotics except for the microbiome therapy where phage therapy, probiotics and vaccines are there in the early trials. But now the biologics are also being considered for patients with bronchiectasis. The non-pharmacological treatment, I'm sure you all know already, is very important to keep the airways clean.
ये तो कंटिन्यू करो.
You could use mucoactive therapies as well, like expectorants, mucolytics, mucokinetics, mucoregulators. Then there are all these devices that are available that help bring out the phlegm from the patient. And of course, postural drainage, which can also go a long way in the chronic of these patients. So the key to home messages for patients with bronchiectasis would be that infection management is phenotype directed. Previous microbiology would actually decide your antibiotic choice. Attempt should be to eradicate the Pseudomonas, and chronic Pseudomonas would be at high risk and merits inhaled suppressive therapy. Macrolides continue to be the highly effective preventive therapy, but one must rule out NTM and monitor the patients for toxicity when on macrolides. So inflammation can be taken care of by the long-term macrolides, but unfortunately not by inhaled corticosteroids. For infection, you would need long-term inhaled antibiotics, but long-term non-macrolide oral antibiotics are not recommended anymore. Impaired mucociliary clearance could be managed with airway clearance devices and mucoactive drugs, but not by recombinant DNAs, which is not a recommended drug again. And for lung damage, pulmonary rehab is very, very essential. Moving on to the next syndrome that I've been assigned, the aspiration syndrome. Aspiration occurs when there is oropharyngeal or gastric content entering into the lower airways and lungs and leading to inflammation and infection there. It's usually an impaired swallowing reflex or decreased consciousness that allows the food particles or even the saliva or the oral contents to go into the trachea across the vocal cords and then cause inflammation, infection, and various respiratory complications. This would definitely depend on the burden of aspiration that has happened, the inoculum, that whether this was infected or non-infected, if it is going from the oral, if there's a poor oral hygiene, then the chances would be that even the saliva would be infected and can cause infection there. And then of course, it would depend on the host factors and the anatomy, that which segment does it go and get lodged. The predisposing factors could be impaired swallowing, impaired consciousness, increased chances of gastric content reaching the lung if there's a reflux or a tube feeding, and if there's an underlying impaired cough reflex, especially after alcohol, stroke, dementia patients, impaired consciousness patients. The other risk factors could be a mechanical disruption of the glottic closure or lower esophageal sphincter, pharyngeal anesthesia and miscellaneous conditions like protracted vomiting, large volume tube feeds, feeding gastrostomies, recumbent position and near drowning situations, a poor dental hygiene, increasing age, and cardiac arrest where the patient has had to undergo a CPR. Now, aspiration is no longer just an aspiration pneumonia. It's a complete syndrome itself. It could start with something like an overt or a silent disease where its consequences depend on the inoculum, acidity, bacterial burden, and host defenses. Or it could be a chemical pneumonitis, which could result from an acute sterile inflammatory injury after macroaspiration of the gastric contents. It could be an aspiration pneumonia if this content gets infected And of course, it could result into complications like airway obstruction, lung abscess, necrotizing pneumonias, and empyema. So, taking each one of them at a time. Now, silent aspiration would be absence of witness choking, the recurrent basal pneumonias, chronic cough with meals, wet voice. So, this is a history that you need to take, especially in elders. You know, when an elderly patient comes and complains of cough not going, and you get a CT scan done or an X-ray done, it shows basal consolidations. You must take history, whether the patient does experience coughing while swallowing meal or drinking water. Even that can be, harmful to the patient at times. If history is not proper, then of course you could go in for more testing, like getting the swallowing reflex evaluated and all. Next is chemical pneumonitis, which could rapidly evolve in patients. Within 3 minutes, there is atelectasis, peribronchial hemorrhage, pulmonary edema, and degeneration of the bronchial epithelial cells, resulting in the release of various mediators like TNF-alpha and IL-8, which by 4 hours, the alveolar spaces are filled with polymorphs and leukocytes and fibrin, and there's grossly edematous and hemorrhagic lungs with alveolar consolidation from the hyaline membranes that are developed within 48 hours. So, immediate priority to patient with chemical aspiration would be protection of the airways, maintaining adequate oxygenation, suctioning of the accessible material, and hemodynamic care. Antibiotics are routinely not indicated, but if started, should be reassessed within 24 to 48 hours and de-escalated or stopped if no infection is present. Corticosteroids have no role whatsoever. Then coming on to the aspiration bacterial pneumonia, this is caused by bacteria that normally reside in the upper airways of the stomach. Historically referred to an infection caused by less virulent bacteria, primarily the anaerobes and streptococci, which are common constituents of the normal flora. But more recent studies have shown that this the microbiology of the oral cavity as well as the gastric, this thing is changing now, and we're getting more of the patients depending on where the patient is coming from. If the patient is coming from community, then you consider the community-acquired bacteria, and if the patient is coming from hospital, then consider the hospital-acquired infections in these patients. So, this is what our newer understanding is. As far as anaerobes are concerned, they're still important. They remain clinically important in only selected group of patients where abscess, empyema, putrid smell, and there's a severe periodontal disease. But not in every patient. So again, it is very important to obtain the blood cultures in patients who are in sepsis, sputum culture. Bowel may be appropriate in ventilated patients or when diagnosis is uncertain and bronchoscopy is otherwise indicated. Anaerobic cultures are difficult to interpret, therefore we usually don't send them unless it's a completely sterile sample taken from, supposing, a transthoracic needle aspiration, and then a sterile sample is taken without any exposure to air anytime. There's a biomarker alpha amylase that you could test, and if positive would suggest aspiration in these patients. Immediate treatment again would be patient's positioning. Head end should be elevated by 45 degrees. Suction of the oral pharyngeal content should be done as quickly as possible. Humidified oxygen is administered. Intubation if required. Urgent bronchoscopy if you feel there are large chunks of food particles that are obstructing the airways, and antibiotics are initiated immediately. As far as anaerobic cover is concerned, there is no need to cover the anaerobic bacteria unless patient has developed an abscess or empyema. ADS, IDSA, ERS, all of them recommend the same. BTS recommends the select antibiotics according to local pneumonia, patient context, and complication phenotype. Aspiration alone is not an indication for addition of clindamycin or metronidazole that we see very happening in many ICU settings and hospital settings. So the classical clinical features of an anaerobic infection would be indolent symptoms, absence of rigors, a predisposing condition for aspiration, concurrent evidence of periodontal disease, sputum that is putrid, and X-ray showing cavitation, and failure to recover likely pulmonary pathogens and cultures of expectorated sputum. Only then would you consider an anaerobic cover. Lung abscess, necrotizing infection with cavitation, empyema, putrid sputum, they would all be indications for starting an anaerobic cover.
वो
not
एग्जैक्ट
otherwise.
रीडिंग नहीं देता है.
Otherwise,
कभी भी
we
आया
broadly
तो
treated
डाउट
as
रहा
a
तो
community-acquired pneumonia
ऐसा
while
मशीन
accounting
से
for
चेक करवा
aspiration-specific
लेंगे.
risks.
वो क्लिनिक
A
हॉस्पिटल में
beta-lactam,
मिल जाता
beta-lactam
है
is
नॉर्मली.
inhibitor is a
एक जगह
pragmatic
मिल
single
जाता है
agent
आजकल.
option that can be used in
बट
these
बहुत सारे
patients.
जगह अभी 60%
And escalation could be
70% वही
performed
मिलता
if
है
you're
हॉस्पिटल
dealing with
में.
MRSA
तो
or
उसमें क्या
Pseudomonas
कुछ करना
risks
नहीं है
in
ना.
the patient.
लगाओ बांध दो बटन दबा दो.
Similarly, HAP-VAP, follow your HAP-VAP guidelines. Anti-pseudomonal therapy is to be added if there's a validated risk for Pseudomonas being present, and MRSA cover if it is meaningful. So if there are no major MDR risk factors, then probably piptazo would be a good choice. If there's substantial ESBS, then meropenem would be a good choice. If MRSA is the risk factor, then teicoplanin, levonorepinephrine, vancomycin, linezolid could be added. If there's a high risk of resistant Pseudomonas, then of course we need to keep upgrading ourselves to probably a ceftazidime, maybe Bactam combination or a polymyxin B combination. But whatever you start, you must de-escalate promptly when the cultures and clinical response permit. This is a very common standard treatment chart depending on what kind of bacteria you're isolating in your community or from the particular patient. But if it's an OPD management, then apoxiclav or ampicillin-bactam are good choices. If the patient is getting hospitalized, then we've already discussed the various options. So I'll skip this portion. So as far as duration of antibiotics is concerned, again, uncomplicated aspiration pneumonia, you need to treat them all for 5 days. But if it is develops into an abscess, necrosis, or an empyema, then of course you would require extended course in these patients. This would be dependent on the response and complications, but one should try and switch to oral therapy as quickly as possible and not just continue the IV endlessly. Bronchoscopy is not required in uncomplicated aspiration cases, but it could be done if the patient is already ventilated or if you're suspecting particulate or foreign body being stuck in the airways and causing a lobar collapse. Dysphagia assessment should be done for these patients. Oral care should be provided so that there is no further aspiration of these infected secretions from the mouth. Feeding should be taken care of depending on what kind of feeding the patient has been given. Soft diet may just be a better choice rather than giving hard diet or lots of liquids. The complications can be ARDS, empyema, lung abscess, parapneumonic effusion, respiratory failure. The prognosis will be associated with higher mortality rather than forms of pneumonia acquired in the community. Asphyxia may result if the aspirated volume of the bland material is large. So this would be a good practical bedside algorithm that aspiration suspected, stabilize the airways, hyperacute syndrome, reassess after 24 to 48 hours for pneumonitis trajectory. If depending on the pneumonia, whether it's CAP, HAP, VAP, and severity of MDR risks, we adjust the antibiotics. This is a good flow chart that you can always see. If the patient is from the community, there's an abnormal radiograph, poor oral dental health, then we give amoxiclav, ampicillin-bactam as choices of antibiotics. If the radiograph is normal, then it could be mild to moderate illness, and then keep reassessing for 48 to 72 hours. And then once the patient is hospitalized, again, depending on whether the community or the hospital, it could be done. So with those words, I'd like to thank you all for a very patient hearing, and we'll be happy to take any questions that you people may have.
Okay, thank you, Dr. Nangya, again for a very comprehensive lecture on both these two topics, bronchiectasis and aspiration. Again, very important, and especially good to see aspiration syndromes getting attention because they are the type of diseases which usually don't get that much attention as probably they should. And very nicely, you have comprehensively told us the algorithm to their approach. Now, I think we can start with some questions, and we have plenty of questions. Let me tell you, so enough to keep both our faculty busy for the next several minutes. So first set of questions are related to the first talk. So I'll address them to Dr. Guleria first. But Dr. Nangia, if there is anything you want to add specifically, please feel free to do so. And the same when the next set comes. So one question here would be, in an Indian outpatient setting where sputum cultures are rarely available, how do we decide which COPD exacerbation really needs an antibiotic versus one which can be dealt with only bronchodilators and steroids alone? So, Dr. Guliri, your thoughts on that?
Criteria, and I mentioned the Anthonian criteria where you looked at increasing dyspnea, increasing sputum, and also looking at prevalence of the sputum in acute exacerbation of COPD, combining that with patients' previous history, associated comorbidities. So if you look at all these clinical criteria, you can take a decision whether this patient has actually a bacterial exacerbation or this is a non-bacterial exacerbation. And then if the patient is having a mild exacerbation, not significant comorbidities, COPD is not that severe, you could actually look at giving treatment without having to give antibiotics. On the other hand, like we discussed in the flow chart, if you have any of the comorbidities or the patient has more severe COPD, or there is purulence of sputum, increasing dyspnea, and increasing in the volume of sputum, you should consider giving an antibiotic.
Okay. The next question would be how to decide on the antibiotics. So, how do we approach the choice of antibiotics in a COPD patient who has frequent exacerbations and probably prior colonization with Pseudomonas versus somebody who has a exacerbation for the first time?
So if you have a patient who is a frequent exacerbation and he has features which suggest Pseudomonas infection, then one would actually want to give anti-Pseudomonas antibiotics. Depending upon your local flora, you could look at various antibiotic regimens, percocet, azobactam, ceftizidime, cefepime, but or quinolone if the tuberculosis has been ruled out. But it would depend on whether you have risk factors for Pseudomonas. So I don't think you should give it for all patients. You should first look at, is the exacerbation likely to be in a patient who has structural lung disease, who has severe COPD, and is there history to suggest that there could be Pseudomonas colonization? If that is there, yes, you should give anti-Pseudomonas antibiotics. But if you have a person who's first time exacerbating, doesn't have any risk factors of Pseudomonas, I think you need to not give high-end antibiotics or anti-Pseudomonas antibiotics. And as I showed the data, even milder antibiotics are good enough for these patients.
Yeah. So I think the message that you want to give is a person who's having exacerbation for the first time and no risk factors for Pseudomonas need not be started on anti-Pseudomonal antibiotics upfront. I think
Correct.
that probably is the. So can you just tell us what are those risk factors for Pseudomonas that one should look out for?
So I mentioned that if you have a structural lung disease, if COPD with bronchiectasis is present, you must keep that in mind. A person who has been hospitalized frequently with acute exacerbation of COPD, likely to have more resistant pathogens, and Pseudomonas could be one of them, especially gram-negative pathogens. A person with more severe COPD with exacerbations, who has low lung function, is also likely to have could have Pseudomonas infection, and you must have a low threshold for treating them. So more severe disease, structural lung disease, and those who have recurrent exacerbation or repeated hospitalization need to be covered more aggressively with anti-Pseudomonas or at least good gram-negative antibacterial cover.
Right. So next question is about asthma exacerbations. We know that they are largely viral triggered. Still, antibiotics are still widely prescribed in Indian practice. So there's a side of kind of a philosophical question. I mean, what drives this overuse and how do we correct it? I don't know if there is a clear-cut answer to this, but any thoughts that you have?
I think there is a big need to really have a lot of awareness and education about antibiotic stewardship, not only in an ICU setting, but also in an OPD setting of how do you decide on antibiotic stewardship. If you were to do an audit, and this has been done in the past, of antibiotic use in OPD settings, and if a medical audit was done in various OPDs, you'd find that more than 50% of antibiotics used in medicine OPD, in various specialty OPDs, are usually not justified. So I think it's a whole issue of awareness and proper antibiotic stewardship, not only in an ICU or hospital setting, but also in an outpatient setting.
Yes, and that actually triggers the antimicrobial resistance to a large degree, isn't it? Because asthma exacerbations, especially we are talking about tertiary hospital, this is a different matter. But if we go in the periphery, there probably it is being prescribed much more than what is needed, and that too incomplete course, maybe not proper dosage also. So all these factors to be kept in mind. The next question is about procalcitonin, which you touched upon with quite a bit of evidence in your talk. The question is there a role for procalcitonin guided antibiotics stewardship in COPD exacerbations in resource limited Indian hospitals? or is it more academic than practical?
So I don't think much role has been that concerned, and I presented the data also, especially if you look at emergency visits. Doing a procalcitonin and just a single procalcitonin really doesn't guide therapy. If you have rising titers, then also you have to show a fall in titers to say that you can de-escalate. So I don't think procalcitonin in our in our resource limited settings has much role as far as treatment strategies is concerned. As I showed to you, there is some evidence which suggests that if you really want to look at it, a much simpler, easier test could be looking at the C-reactive protein, which may help to some extent. But you have to look at clinical judgment, and these biomarkers are only to help you as far as clinical judgment is concerned. They will not be the driving force as far as treatment strategy is concerned. That will depend on the clinical profile of your patient.
Correct.
When I
And
come
again, yeah, Dr. Chavla.
Yeah, one thing, we as a senior have a lot of responsibility because all juniors follow us in the hospital, in medical colleges, wherever. If we are using for a long time and we are using for viral, then they follow. I'll tell you a very interesting example. In our hospital, after this course has started, all of them have joined. And now suddenly everybody, should we stop this, sir? Should we? Suddenly it has, because we have started stopping drugs so frequently. So every student, they actually tell me, sir, should we stop this? So I think we as a senior and teaching and education, probably repeatedly, because otherwise, you will be surprised many times in the ICUs. The antibiotics goes on just like 18 days, 19 days like that. People don't stop.
Dr. Nangia, what's your take on procalcitonin in a nutshell? How should it be practiced?
So procalcitonin is a very good biomarker, especially used for prognosticating the patient's clinical condition in the hospitalized patients. It doesn't help in identifying the infection or in ascertaining that this is an infection only and not an inflammation, nor does it help in differentiating between a gram-negative or a gram-positive infection. These are all the concepts that we evolved with over the years. Initial concept used to be that if you're finding a procalcitonin very high, then it could be a gram-negative infection. If it is not very high but marginally high, then a gram-positive infection, but it may not be high in localized infections. But over the years now, with all the studies that have been conducted, our own experiences, we've realized that procalcitonin does not help you in diagnosing an infection, but it certainly helps you in deciding your antibiotic course as the patient is hospitalized, during the hospitalization of the patient. If the procal initially was high and then starts coming down with your treatment and the patient is also clinically stable, then you can consider reducing the antibiotic load in these patients. So it can be used more as a de-escalation strategy as a part of the antibiotic stewardship program.
So I think everybody is saying the same thing almost in a way. Let me, at the cost of 2 extra minutes, let me post a slightly different type of question on this to all of you, maybe starting with Dr. Guleria. And this is not related to, say, if a patient with ILD comes. Many times we see patients with ILD. Acute exacerbation, or ILD with acute exacerbation, we have to decide if it is an acute ILD exacerbation versus a superadded infection of a virus or something. That is a very common scenario. How should we decide? Does procalcitonin help in this particular situation? If it is high, would we say this is more likely to be an infective process? What is your take on that?
Acute exacerbation of ILD or any worsening of COPD, also acute exacerbation of COPD. As has been said, procalcitonin has not been shown to be a good marker to predict whether this is a bacterial infection or not. A rising procalcitonin also will tell you how it can help you to prognosticate it. If you're giving antibiotics in a patient and the procalcitonin starts falling, and you can have cutoff of more than 50% or whatever cutoff you want to use, then you could say that you are justified in de-escalating therapy. So decision to give antibiotics cannot be based on procalcitonin. It works both ways. You could have a bacterial infection and procalcitonin may not be high, and you may have high procalcitonin which may not be that much of a bacterial infection. So I think it's important to keep that in mind. The decision to give antibiotics should be based on other parameters rather than only a procalcitonin directly therapy. I showed you one slide which was by one person, Schultz, who is a big proponent of procalcitonin, and he's tried to develop a logarithm looking at cutoffs when you should consider it. But I don't think there's enough evidence to support that protocol that he has tried to put forward.
I think the bottom line probably should be that in isolation, procalcitonin should not be used as a indicator to start antibiotics probably. And I would say a falling trend is more helpful rather than a
Correct.
high or a rising trend. Probably if that message goes across, it would be I think beneficial for most, right?
Dr.
So
Anand,
next question.
it is not that easy also. The example you gave, many a time ILD presenting, he's on steroids, he's not raising fever, he's hypoxemic, you really don't know what is going on.
Sir, that is why I give that example. And that is why I give an example to 3 such experienced people. Otherwise, I would not have given that example.
So if a
That is
patient with
the
ILD
problem which we all
exacerbation comes,
face.
you will in any case start them on empirical antibiotics and then monitor them.
Yeah.
You know, the
So I don't think
procalcitonin here will be useful in de-escalating your antibiotics. So if you found the procalcitonin levels very high initially, in the next 2-3 days time, is it declining or not? We'll show you whether the infection is coming under control or not, one. And second, if the procal levels remain static or remain low, then again after 2-3 days, you are safe in de-escalating the antibiotics further.
So I think what I would say, Anand, is that if you had a patient like that and you had low procalcitonin, would you be brave enough not to give antibiotics?
Exactly.
Yeah, exactly. So, sir, if a person comes to
You have an
hospital,
acute
he's
exacerbation of
hypoxic in
ILD and a
respiratory
patient
failure,
very sick.
most of the time we will give empirical antibiotics to begin
Correct.
with. Yeah.
So you would not base your, just because procalcitonin is low, you will not say that an acute exacerbation ILD where you could have multiple things going on, antibiotic would not be justified. So I think procalcitonin alone cannot be used as a guide to antibiotic use or not to use antibiotics.
Yeah. Okay. I think so. We'll move on. The next question also I think you have addressed in your talk, but still no harm in just repeating once quickly. How long should antibiotic therapy actually be given in acute exacerbation? Are we still over treating for 7 to 10 days when 5 days might be sufficient?
Yes, like the data I showed you, 5 days antibiotic is usually sufficient. There is one study which I showed which used 2 days antibiotic, which I was pretty surprised. But what we're trying to say is that I think antibiotic usage, especially in patients who have mild to moderate exacerbation, does not need to be for very long, and there is more and more data emerging that you can give it for shorter duration. But you have to individualize it. If you have a more sick patient who has severe exacerbation in the hospital, you may have to give it for a longer time, but there is no data to suggest that in most patients you need to give prolonged antibiotics from 7, 10 or 14 days. A 5-day course is usually enough, and you should de-escalate if your patient is improving.
Dr. Anand, we need a study in our country. These are studies from abroad, most of them. We need these studies to convince people to give a shorter duration, no?
Right, sir. So I think the logical thing would be after we have to daily assess the patient every day. Obviously, we have to do that, and as soon as we find the parameters are improving generally overall, then that is the time. There may be 1 or 2 days up and down, but I think it should not be that you give for 10 days when 5 were enough. I mean, at least that kind of a major deviation should not happen. Okay. So next question I think again is on. So in patients with frequent or recurrent steroid antibiotic courses for exacerbation, how should we counsel them about the long-term risks? One, of steroids, and secondly, about resistance. So this is about patient counseling of the risks of repeated courses of steroids and antibiotics.
One is oral steroids, other is inhaled steroids. So one issue that came up when we looked at COPD patients, and there were a number of studies starting the TORCH trial, which showed that if you give inhaled corticosteroids, there was a higher chance of pneumonia happening in these patients, and that led to us moving away from the triple combination, long-acting LABA-LAMA combination in patients with COPD because of the fear of pneumonia. But subsequent data did show that this is not something that we need to be that much concerned about, because severe pneumonia was not that common. And now if you look at it, things, we've gone back to what we were doing in the early 2000s, the triple therapy of ICS with LABA-LAMA in severe COPD, especially if the eosinophilic phenotype is useful in decreasing exacerbation. But having said that, recurrent courses of oral corticosteroids should be discouraged, because they do lead to not only chances of recurrent infection, but lead to number of steroid related side effects, and that patient need to be counseled, because in our setup, what the patient does is sometimes they don't want to take the inhaler or the nebulizer, they would just pop a course of steroid, or the local GP will give them a course of steroids, which then becomes a habit as far as these patients are concerned. It could be asthma, it could be COPD, much more in asthma exacerbation, and this leads to more and more side effects as far as steroids are concerned. So it's very important to counsel patients properly.
And I think the next question was very similar to what you just said. Do inhaled corticosteroids and COPD actually increase pneumonia risk? So
correct. So I just mentioned that if you look at inhaled corticosteroids, we had this whole issue of higher chance of pneumonia. I think now the data suggests that the risk is not that high for severe pneumonia. You can still get pneumonia, and we have been using inhaled corticosteroids for a long time. I don't think there's a huge increase as far as pneumonia is concerned because of inhaled corticosteroids.
I would actually say that for the last 20 years back, there was a real scare about pneumonia and steroids in the Western countries. In every international conference, this used to come up as a huge issue, and our side people never seem to agree actually, because we have not seen so much. We have been using it so much, and now, like you said, they are now coming around in a way. Now, inhaled steroids are being given at every level, in asthma also and everywhere.
And
Okay.
especially with budesonide, the chance of pneumonia are lesser as compared to cortisone.
Correct. Yeah, right. The next question is of a COPD patient who's on home oxygen therapy. If he exacerbates, how does the choice of antibiotic or the setting change?
If you have long-term oxygen therapy, he will automatically becomes a severe COPD patient. He has, that means, compromised lung function, and he therefore falls into the category of having more severe COPD, which increases the chance of having more resistant infection or more severe infection. And you would give a higher end antibiotics rather than just giving amoxicillin or macrolide or doxycycline in such patients. So then in these patients, as I showed in the flow chart, you would actually tend to give higher end antibiotics, because two things. One is he is at risk for higher infection, and for him, each infection can lead to a more rapid decline in lung function, which can actually cause more problem as far as he is concerned, because he's reached that stage where even a small decline in his FEV1 can be quite serious as far as his overall prognosis is concerned.
Okay, so this is the last question from the asthma and COPD segment. A young asthma patient who has exacerbation and greenish sputum. Kind of interesting question. How would you clinically distinguish a true bacterial trigger from an eosinophilic inflammation before starting antibiotics?
So like I said, greenish sputum can occur because of eosinophilic inflammation, and that is being recognized more and more. So you need to look at other factors. Does the patient had fever? Is he toxic? Are there findings which suggest that there could be a patch of consolidation, crepitations or bronchial breathing? Or does the X-ray show a patch? If any of these features are there, then you are looking at possibly a bacterial infection. Bacterial infection tend to be less common as far as exacerbation in asthma is concerned. Therefore, you need to look at all of these factors before deciding on antibiotic use. Otherwise, these patients may not need antibiotics, and this greenish color could be just because of eosinophils getting degraded in the sputum. The important thing to remember here is that we reflexively give a lot of antibiotics to these patients, which may not be indicated, because majority of asthma exacerbation are not because of bacterial infections.
Okay, so we'll start off with the segment on bronchiectasis questions, and I'll address them primarily to Dr. Nangia, but other faculty are more than welcome to chip in with their inputs. So Dr. Nangia, in Indian patients, post-TB bronchiectasis remains very common. So does the underlying etiology change your strategy of antibiotic selection, long-term antibiotic selection, and airway clearance strategies?
Not really. I think ultimately it will depend on what bacteria you're isolating, the microbiology rather than the etiology. Etiology requires treatment if there is a pathology which can actually be treated. Like if you have an RA, angstpons, ABPA, then you would want to treat those. But if not, then you only focus on the bacteriology or the bacteria that you're isolating and then treat that accordingly, irrespective of the etiology.
Okay. Now, there is a bronchiectasis patient who has been receiving antibiotics intermittently for exacerbations. So this is the question. But at what situation will you decide that now he requires long-term suppression antibiotics?
So basically, I think the criteria should be the number of exacerbations that the patient undergoes in the previous year. If there are 3 or more exacerbations, patient definitely requires a long-term inhaled therapy. If it is 4 or more, then oral plus inhaled. And if it is 5 or more exacerbations, then he has to go in for an eradication kind of a modality where you give IV antibiotics first, followed by prolonged inhalation course.
Right. So does it also mean, suppose a cystic fibrosis, suppose he's chronically growing Pseudomonas or any disease for that matter, then you would say at this time he is a candidate for long-term antibiotics?
So we try the eradication therapy first, 3 months eradication treatment, where it involves 14 days of IV antibiotics followed by remaining 3 months of nebulized colistin or tauramycin, one of the two agents. If that fails, or despite that there is recurrent colonization and recurrent, but those colonizations should also be associated with deterioration in lung functions, symptomatology of exacerbation every time, then of course you would have to keep treating them as and when they isolate the Pseudomonas.
Right. Okay. What would be a practical approach to the airway clearance techniques in India? You know, you have told us about the available options that we have, the devices, etc. But we also know that they are very, very limited as far as their availability is concerned. So, how do we approach the airway clearance, especially where these things are not available in majority of the parts of the country?
So I think one way is chest physiotherapy and drainage. Postural drainage is something very simple and very easy to do. You just need to know which lobe of the lung is involved and then teach the patient accordingly which one to keep higher. You know, whichever portion of the lung supposing is the right lower lobe that is involved, then you keep the right lower lobe higher and the head down so that there's a proper drainage of the secretions. And this of course could be added with some mucolytic, some mucokinetic agents which are easily available. I mean, dime a dozen available these days. So many syrups, so many preparations that are available that can be used. Along with, if nothing else, then just humidification and steam would also work in these situations.
Correct. So I think at least these are much better than at least nothing, and they are very effective also. I think if they are done properly, they would be very effective. The other devices are also there, but that if they are not there, it doesn't mean that one cannot perform airway clearance maneuvers wherever
All these
the person is.
acapellas and aerobicas, they've just come recently. Otherwise, what we
Yeah.
were earlier, we were only teaching our patients postural drainage that lie down on the side which is infected higher and keep your head down and it'll drain automatically.
And an aggressive chest thumping is something that is also very easily done, and that's pretty useful. Okay, so the next question is about what we just discussed some time back, that about Pseudomonas colonization and bronchiectasis. Suppose if one isolates it for the first time in bronchiectasis, how does it change the management plan for the first time?
So I guess this is what we're looking at is somebody who's exacerbating for the first time and now is developing a Pseudomonas infection. You would treat them for 2 to 4 weeks with nebulized antibiotic and inhalation therapy for 2 to 4 weeks. If that takes care of it, well and good. If the patient keeps on going into recurrent exacerbation, that is when you will consider the eradication regime for them.
So so initial treatment of this will not involve injectable antibiotics?
So again, will depend on how severe the exacerbation is. Since it says that only isolation, that is why I said that you just use inhalation therapy. If the patient has a serious kind of an illness which requires hospitalization, then of course IV antibiotics followed by inhalation therapy. There are times when the patient comes to your OPD and you get a CT scan done which only shows bronchiectasis and the bronchiectasis doesn't even show mucus filling in any of the bronchi. Patient is not patient is not running fever, but it's only worsening of breathlessness and cough and phlegm. And you isolate this, there is no patch, there is no consolidation, then probably IV antibiotics may not be needed. In that situation, only nebulized treatment may just be sufficient.
Okay, so actually, we have not really gone into the macrobiological aspects of things in this particular seminar. This is purely clinical oriented. Suppose, does the colony count have anything to do with this decision of treating with IV or inhalation or long term, short term?
Yeah, sure. So, of course, the more dense the colony is, the more chances that the patient will require a prolonged kind of a treatment. But unfortunately, the colony count that we look at is only the sputum and not the colony count that is present inside the lungs of the patient. So sputum examination, of course, in an acute exacerbation phase, you may get a higher colony count in these patients. But again, quantitative tests are not available everywhere. So you need to rely a lot on the symptomatology of the patient and the history that is being given by the patient. So again, I'm saying that if there is no fever, there is no patch on the CT scan, like a consolidation, if it is only cough, phlegm, and bronchiectasis, and not even too much of mucus plugging inside, then probably inhalation therapy is sufficient enough. If it is anything beyond that, then IV anti-pseudomonal drugs followed by inhalation therapy is what would be recommended in these patients.
All right. So the bottom line is we have to rely on a conglomeration of clinical, radiological, and maybe some biochemical parameters, and not just on microbiology. Of course, if it is there, it will definitely help us. But we have to learn to decide without that as well. Okay. So the next question, in aspiration syndromes, do you differentiate clinically between aspiration and aspiration pneumonitis and aspiration pneumonia? Because the treatment of both are different.
See, basically, I fully appreciate, one is theoretical and one is clinical. When you also get an aspiration patient, it's the same way that if you get an ILD exacerbation, will you not start an antibiotic? Similarly, even here, you would start an antibiotic. But theoretically, if you were to differentiate between aspiration pneumonia and, this aspiration pneumonitis, the chemical pneumonitis, we would not call, chemical pneumonitis, the only way of differentiating would be that when you have a chemical pneumonitis, patient would have a dry cough, not so much of phlegm coming out, no fever, whereas in an aspiration pneumonia, there would be frank history of cough, phlegm, food particle coming out, vomitus coming out, fever being associated. X-ray will show more like a consolidation, whereas in aspiration pneumonia, you may just get subtle GGOs in the lungs and nothing more than that. So the idea here is to follow the principles of antimicrobial stewardship program, and if one was to be a very stickler with the rule, then not give any antibiotics. But the strategy that we use is we start the antibiotic and then watch it over the next 2-3 days. If the patient shows very good recovery, then you just de-escalate and stop the antibiotic within the 48 to 72 hours and not give a prolonged course. But if the patient develops into a pneumonia and continues to run fever, then you may even consider bronchoscopy on the third day to look for any endobronchial obstructions and continue the antibiotic for a prolonged period.
Okay. Next question, again, a clinical one. An elderly person, recurrent aspiration due to dysphagia, which may be of any cause. What is your threshold for recommending a feeding tube versus continuing oral therapy with some modification of the diet?
So I think this is something that will depend on the dysphagia assessment test that we do in our patients. If the patient only had dysphagia towards liquids, then I think changing the consistency to about a semi-solid kind of a diet may just be a better option. Because putting in a feeding tube is also not an option, because even with the feeding tube, there could be aspiration happening. Why? Because feeding tube, what does feeding tube do? Feeding tube actually bypasses the gastroesophageal sphincter, which then remains patent. And the chance of aspiration are even higher in that situation, especially if the patient is not kept in a propped up position or in a prone position most times. So of course, first and foremost would be use of speech therapists to help them swallow better, improve their swallowing reflex. Then if that fails, then try the semi-soft diet kind of a situation where you don't want to avoid the liquids to which the patient may be aspirating. If that doesn't help, then go in for probably a PEG would be a better answer then, where PEG is able to take care, of course, PEG is also not free of aspiration, but the chance of aspiration are the least when you're doing a PEG or a PEG.
Yeah, I agree. I think in situations where, and there are many times a person does not tolerate long-term NG feed as well, In fact, we even right now have a patient admitted, a very elderly male, and he's just not allowing the RALS tube to go in. He keeps pulling it out. Now we cannot send him home on this if he's not willing for that. So all these problems happen, and that is why sometimes a PEG might be the option. Otherwise, but of course that is the last option.
Nowadays, they do FEES, fiber optic evaluation, endoscopic evaluation of swallowing. That is nowadays ENT, whenever you have problem, they give feed, they give 2-3 kind of feeds and see whether patient is able to swallow. Nowadays, that also is practiced.
Yes. And many times they may have, vocal cord palsy and all these things are there. So all these factors kind of contribute to the aspiration. All right. So the last 2-3 questions are there before we wrap up. Do you see any role for macrolide therapy for its anti-inflammatory effect in non-CF bronchiectasis?
So of course, macrolides do have an anti-inflammatory effect, and we've seen that in patients with COPD also, as well as in patients with asthma, where we do use it for its anti-inflammatory effect. So macrolide would have a dual purpose, antibiotic as well as anti-inflammatory effect in patients with the non-cystic fibrosis bronchiectasis, especially if there is a bacterial colonization also happening. So it has a dual role in these patients.
Bronchiectasis who keeps growing non-tubercular mycobacterium on repeated cultures. Whether it may be a colonizer or a true pathogen requiring treatment, how do we know that? What should we do? I think that depends heavily upon the microbiology, doesn't it?
Absolutely. And also will depend on the radiological picture of the patient. If there are train bud appearances, cavitations developing, fibronodular opacities, and bronchoscopy also results in NTM, then of course you would want to treat it aggressively rather than ignoring it.
Yeah, I think there's no question about that one. Uh, in your experience, how often is silent aspiration missed in the ICU and ward? And can there be any bedside clues to make us suspected even without doing a formal swallow study?
Well,
I
as
think
I
I think
said,
it's a
what is
pretty
this?
important question, especially for the bedside people, students, and all. How to suspect aspiration, in
I
other
think
ways.
what is foremost is a proper history taking. Once the patient says that there is a cough, and cough is, you must try and, especially in elderly patients, in patients with CVA, strokes, patients with impaired swallowing for some reason or the other, vocal cord palsy is one of the most common reasons. So in them, it is very important to take history whether the cough happen, and especially those who have this, vocal cord tumors, the tumors around the glottis, where they are unable to differentiate and they are not able to figure out whether aspiration is happening or not, because the vocal cords also lose their sensitivity over a period of time.
Laryngeal tumors.
Laryngeal tumors and all.
And not only that, I think even in the ICU itself, once a patient is there, then say pooling of secretions, heavy amount of secretions coming when we are doing the throat suction and all these are factors which probably would lead us to, suspect more that there are more chances of aspiration going on. So either we do a tracheostomy or whatever to try and bypass that. So, okay, so we'll come to the last question and then I think we'll wrap up with maybe a couple of comments from all. What does a realistic long-term bronchiectasis care plan look like in an Indian setting? Again, a very philosophical question, holistic type, asking you to kind of sum up everything in one go, where a CT, sputum culture, and specialist follow-up are not always accessible to all patients. Now, I don't know how you are going to answer that, but please try.
No, so basically again, these are situations where you need to use on rely on more on home remedies, chest physiotherapy, postural drainage. These are all very important aspects of clearing out the lungs from within. Use of mucolytics, mucoactive agents which are easily available, and percussion therapy. So all these can be done very, very easily at home. There's no problem.
Yeah.
Can I say
I think
something?
we have finished with the questions. Yeah, Dr. Chawla, please come in.
One of the things which is not given importance in all these years is a pulmonary rehab for our respiratory patient. I think this is an area which really requires a lot of inputs, and every center to have a pulmonary rehab. This can make these chronic patients, ILD, bronchiectasis, the COPD patient life very comfortable. And similarly for bronchiectasis, if they have the pulmonary rehab in every hospital, wherever, because this is considered as a chest physio. It is not only the chest physio, it has nutrition, it has exercises and other things. We have started recently doing, and I find the quality of life is really very good of these patients. Although the lung function may not have improved, but the quality of life is much better.
No, there's no doubt about that. I think, Dr. Chawla, you're absolutely right. And I think in the last 10 years, although it has improved the awareness in our country, but still a lot needs to be done. In European and Western countries, in fact, dedicated rehabilitation centers are available at every peripheral town also. Multiple centers at every peripheral town, and they are not only respiratory, they are multimodality, in which orthopedic, etc., is also extremely important. So they are manned not only by a doctor, but they are manned mostly by trained physiotherapists. And that takes the rehab to the periphery. So a person doesn't have to travel to a tertiary care setup. And probably when we start decentralizing these rehab centers, that will be the time when we can really say that this is really catching up. So
And
thank you so
rehab
much.
should also, Dr. Anand, rehab should also include a nutritionist and advice for vaccines. That is very important.
Yeah, absolutely. It's a multimodality, no doubt. In fact, some people even say add a psychiatrist, psychotherapist, and all these things also should be there. Fine.
Dr.
I think
Guleria was saying something.
Yeah.
He was saying
So I
something.
think also need to be a psychologist and also a nutritionist. And I think in our country, since it's not going to be practical, we should look at things like tele-rehab also. That you can do a hybrid programs to teach the patient first for first few weeks and then continue it. I think Anand would remember we had done studies on this many years ago and showed that it works. You could start with the first few weeks of rehab in the hospital and then followed by tele-rehab for the subsequent as a 12-week course, and it was pretty effective.
Actually, we are still following that. When we started that, we found it was working, and now it is regularly ongoing, and online group sessions are also ongoing. So I think we have almost taken it up as a routine. I think that's very useful. So I think now I'll wrap up here from my side, Dr. Chawla, with the thank you to both our eminent speakers, Dr. Guleria and Dr. Nangia, for wonderful lectures and taking the questions. And I'll hand it back. Dr. Akanksha, is there anything from your side first before I hand it back to Dr. Rajesh? I think you have given us such a nice overview in the beginning. And next time also you will give us an overview of what we said today. So
Yes.
anything
Even
from
the
your
questions
side?
are included. So whatever.
Sir, I think for me, sharing the platform with Kuleria sir, Nangia sir, and you and Dr. Chawla sir is in itself a great learning. I'm learning with every session. And today also I learned that you just don't rely on the labs. You see the patient overall. You relate the clinical presentation, and then you decide. And the importance of the rehabilitation and the integrating it all together. So I think, sir, with the next time, I hope I'm able to justify the recap of what is taught by Guleria sir and Nangia sir today.
Okay, thank you very much. Dr. Chawla, I'll hand it back to you now.
So with that, I thank you, Dr. Anand, for wonderfully one of the longest session we had today. Thank you so much for moderating it well, Dr. Guleria. He was extremely busy, but he made it and took a lecture. Dr. Vivek Langia, again a very busy clinician. Thank you so much for giving wonderful presentation on this subject and discussing post-lecture the practical aspects of these things. They look very good in books and lectures, but when you have a patient, then these things what we discussed really are helpful. So with these, I also thank Dr. Akanksha for, she's busy for last 4.5 months because every week there is a talk. And with this, I also thank Lexicon for conducting it nicely, and also the Zyme Bioscience Life Biosciences who have supported this event. And I think the people who were there, a very large number today, and for encouraging us. And we keep on going with your encouragement. Thank you very much. And next time we'll meet next Tuesday. That's on pleural infections, the lung abscess and necrotizing pneumonia. So meet you again 7:30 p.m. next Tuesday with the module number 19. So only 6 are left after this. Thank you very much.
Thank you, sir.
Thank you. Thank you very much. Good night, everybody.